everyone who is present in the chamber and those who are listening online to the business of the Health Scrutiny Committee for Lincolnshire. I would also add that for those of us in the council chamber, there is no fire drill planned this morning. In the event of the fire alarm sounding, we need to leave the council chamber through the rear doors, through reception and assemble in the car park at the front of the building and await further instructions. I would also request all members to place their phones on silent and to ensure everyone has the opportunity to ask a question, to try and keep them to a maximum of 2 questions per item and to keep them concise and succinct. I'd now like to move into agenda item 1, apologies for absence and replacement members. Trina.
Thank you, Chairman. We've received apologies for absence from Councillor Whittington, and we've also had apologies for absence from Councillor Sue Woolley, Executive Council for Community Engagement, Registration and Coroners. Thank you, Chairman.
Thank you. I'd also like to welcome Liz Ball, who is attending her first meeting of the committee as the Health Watch Lincolnshire representative. Welcome back in a different capacity. It's lovely to have you. We'll move into agenda item 2, declarations of members' interests. Do members have any interest to declare at this point, please? No. Should any arise during the meeting, then just please make me aware. We'll now move on to agenda item 3, the minutes from the 14th of September, which were held on the 12th of October 22. I need to confirm these minutes, which you will find on pages 3 to 6 of the agenda pack, and as the committee have had the opportunity to read these in advance of the meeting, I plan on taking these on block. Is there a proposer for these, please? Thank you, Councillor White. Seconded, Councillor Raywoodson. All those in favour, please show. Thank you. No, any abstentions? No? Oh, Councillor Hay, thank you. Okay, that's carried. We'll move on to... Yeah, I understand. Yeah, thank you. And we'll move on to item 4, the minutes from the 12th of October. You'll find these as on page 7 to 18 of the pack. And once again, as the committee have had the opportunity to read these in advance, I'll take these on block again. Once again, can I have a proposer, please? Thank you, Councillor Allen. Seconded, Councillor Wootton. All those in favour, please show. Again, abstentions. Thank you. Those against? No. Thank you. That's carried. In which case, we'll now move on to agenda item 5, the Chairman's announcements. My announcements have been circulated with the agenda on pages 19 to 28, and the supplementary announcements were circulated on the 8th of November. Are there any questions on these, please? No, in which case do I have a proposer that we note these? Thank you, Councillor Linda Wootton. Seconded, Councillor Allen. And all those in favour, please show. Thank you. That's supported. In which case we'll now move on to agenda item 7. But before we do, I will just say there is a change in the layout of the agenda this morning because of the availability of NHS colleagues. The committee will be taking the 3 GP-related items first in the order they appear on the agenda, with the clinical care portal taken after these 3 items. So we'll now move into agenda item 5. This was 7. This was circulated as part of the agenda pack on pages 37 to 42. And I'd like to welcome our presenters via Teams. Dr. Reid Baker, Medical Director of the Lincolnshire Local Medical Committee, and also present to respond to any questions is Sarah Jane Mills, Director for Primary Care and Community and Social Value, NHS Lincolnshire Integrated Care Board. I'll hand over to you, Dr. Reid, just to give us a rough run through the papers, and we'll take questions at the end. Thank you.
Hi, good morning, everybody. Thanks for having me. My first committee attendance, so I hope I explained things appropriately for everybody. My name is Dr. Reid Baker. I'm a GP at Woodall Spa New Surgery. I'm a co-clinical director for East Lindsey PCN. I'm here today primarily as my role as medical director for Lincolnshire LMC. So if it's okay, I'll proceed. Obviously, hopefully everybody's seen my report that I submitted to the committee. But as an overall summary, essentially, general practice in Lincolnshire is continuing to work tirelessly and try and help our patients during a time of ongoing significant challenge. And about 90% of all contact with the NHS is via general practice, with the needs patients have been quite wide-ranging in terms of support. Those needs have and will continue to change, both in terms of increasing age and medical complexity, and the expectation for rapid access to one-off episodes of care for younger, usually fit and well patients. But general practice has seen significant challenges, both due to and independent of the pandemic. General practice and our patients have both experienced the anxiety, restrictions and consequences of the pandemic, as well as changing NHS and political landscapes have brought. As I outlined in my report, some of the challenges faced within general practice and for their patients are significant workforce shortfalls, increasing demand for appointments, and increasing hospital waiting lists, which unfortunately have impacted on general practice workload and the patients that are waiting to see our colleagues in secondary care. And we do still have, unfortunately, ongoing COVID absence within general practice staff. Despite all those challenges, we're providing more services than ever, and appointment levels are significantly in excess of pre-pandemic levels. I think in addition to the August 22 data that I submitted, which showed a 25% increase in year-to-date appointments compared to 2019, the September data has come out and we've seen about 414,000 appointments in September in general practice, which is up again on August 22, which was 391,000, and is about 20% higher than the same period 2019. So general practice strives to do its very best for patients we care for, and in the face of so many ongoing challenges nationally and for us and our patients and the wider health and care system, we appreciate there may be frustration among some of our patients, and we share those frustrations, but we want to be clear that we also want high quality, safe and timely service for our patients when they need it. General practice in Lincolnshire needs the support of our patients and your good selves to be a voice by our side for a sustained and appropriate resourcing infrastructure and workforce, not only to support our service and the incredibly hardworking colleagues who look after you in your practices currently, but also to enable general practice to continue to evolve and to support our increasing population and their healthcare needs in the future. And our world has changed an awful lot over a relatively short period of time, and it will continue to do so. There's a wide range of advice and services for our population to access, healthcare advice and self-care, as well as traditional general practice appointments. And these options have increased rapidly. As the world changes rapidly, there's a risk that as a wider health and care social system that we've so far not quite succeeded maybe in signposting our population in the navigation of all these systems so that they've not been optimized as well as we possibly could for patients. But healthcare advice and education really needs to be at the heart of everything that we do in the Lincolnshire integrated care system, and empowering our population to be confident in self-care as well as navigating the services we're offering will help people get the right help from the right place when they need it and sooner. And it will also allow capacity in services such as general practice to help support patients when they need it the most. So in summary, the needs of our patients will evolve, and we will continue to evolve in general practice, but what will always remain is that Lincolnshire general practice and our patients both need to support one another, and then together as part of the wider system we can hopefully attain the best possible health outcomes for our population. So that's a brief summary. Hopefully that's a useful overview of my report, and thanks for your time so far today.
Okay, thank you. We'll start with questions then. Councillor Smith, with you just arriving late, we have rejigged the agenda for today because of the way that the speakers need to come in with availability. So we're actually on agenda item 7 as it stands. Okay, I'll start with Councillor Wootton, please.
Thank you very much indeed, Mr. Chairman. I'd like to highlight to the committee today about did not attend the by own circumstances 2 weeks ago is that I contacted our local GP service in Vine Street and could not get on to ask my GP for 2 days running, and the next day found out that despite the fact that 4 GPs were on duty, over 100 appointments have been seen during that week to get a blood test. The equivalent of 250 minutes worth of nurse appointments were missed, which you could say for 25 people didn't turn up to GP surgery. And I wonder what we could do to help highlight this particular problem.
Thank you. So forgive me because I've not been to committee before. Is that a question directly for myself?
Sorry? I was talking to the chairman. Thank you.
Thank you, Councillor Wootton. I think from our point of view, we just need to ensure that we make it clear to any of our residents that, you know, if you do get these appointments, you must attend, and if you can't, you need to cancel them, because people are, as you rightly say, you know, desperate to get an appointment, and it's very, very difficult often to. So, and I think also we see in our GP surgeries when we're in there are signs about people, you know, letting them know. So we just need to make sure that we've got that clear message, and we let our residents know.
Chairman, I don't have the figures yet for non-attendance that the GPs plan getting out to see the doctors, because I understand that problem is still a big problem as well, particularly in Vine Street surgery. Over 100 patients miss their appointments, so there must be something that we can do as a committee to highlight that.
Yes, certainly. We'll probably pick it up with Sarah Jane outside of the meeting and see if we can't share it out to our colleagues on districts as well. Thank you, Councillor Wootton. I've got Councillor White next, please.
Yes, thank you. I'm interested in the data, 391,062 appointments. Is there any more detailed data behind this? For example, does it include digital and in the practice appointments? And does it include appointments with any personnel within the medical practice? Thank you.
Sarah Jane, you want to respond?
Yes, I'm sure Rita will want to come in. The data is based on information that is fed into the national system. What we know is that actually it's an understatement of the activity. It doesn't capture all of the digital appointments. It will capture some, depending on how the practice record their appointments in their clinical system, but it definitely won't capture all. Similarly, it will capture the appointments of colleagues employed within the GP practice, but it won't capture the data that is provided by the primary care network staff. So the first contact physios and colleagues like that necessarily. So the data is actually an understatement of the activity, but I think it gives you an idea of just the volume of contacts that general practice colleagues are having.
So it doesn't specify exactly who people are seeing?
We can see whether they've seen a GP or another health club, another clinical profession. So we have got that split. So whether it's a GP or another clinical profession.
Thank you.
Thank you. Before I take my next speaker, just building on to Councillor White's question, I did notice from the BMA's paper that COVID vaccinations are classed as a general practice contact. However, most general practices do not deliver these. Then you have appointments with nurses or other healthcare associates, so surely the stated increase in actual GP appointments is not an accurate picture.
So if I could come back in, I don't know whether Reid wants to add anything. So the Lincolnshire data does not include the COVID vaccination activity. It is taken out of that. It does include nurse practitioners or colleagues working within the GP practice, but as I clarified, it doesn't include some of the extended roles that I will talk about when I discuss the primary care networks. So it is an understatement, but it doesn't include the COVID vaccination activity.
Okay,
Yeah,
thank you.
If it's okay if I come back in, is it okay if I come back in just there to build on that point? Sarah Jane understands the data much better than I do. I'll be the first to admit that, but she's exactly right with what she says. I think although that data is not included in the appointment data in terms of the COVID vaccination, obviously general practice is partaking in the COVID vaccination booster for the autumn. You know, significant numbers of staff from practices, be they working under PCN delivery models or practice delivery models, are doing COVID vaccinations above and beyond those appointment levels that you've seen in the data we've provided. I hope that helps to clarify.
Okay, thank you. Councillor Parkin.
Thank you, Chair. Really interested in the presentation and in the papers. And one of the things that Reid was saying was that we've got a very rapidly changing environment and very rapidly changing world. And I just want to challenge the reality of that a little bit, in fact, because for great swathes of our residents, they are being left behind in that. And I think we do have to have a really kind of gentle, careful recognition that, yes, those changes are rapid, they're irreversible, but there's great chunks of our community who aren't part of them, and I believe are feeling increasingly frustrated at being left behind. And seeing as they're the kind of core of our residents who are likely to have most need for health services, we can't move on to such an extent that we just leave those people sidelined. So there is a question from there as well as an observation.
Forgive me, I'm still not au fait with the etiquette in committee. Is it okay if I come back to that point? No, I think I totally agree, and I think all my colleagues would do across general practice. That the world has changed rapidly. In many ways, we think there's positive changes, but we know that some things that have changed have happened very, very rapidly. So the adoption of digital solutions in terms of online triage and online appointments was something that was rolled out primarily due to the COVID pandemic, but it had already been coming along to differing degrees in different areas. And yeah, some of those patients you refer to, quite rightly, they have the most complex medical needs and may not be, and we shouldn't assume, because some of my older patients are fantastic with some of the solutions, but we shouldn't assume that is the case with everyone. You're quite right. And that's part of the work that's going on in the system at the moment, and is accelerating in terms of addressing those health inequalities, be they digital literacy, be they access to digital devices themselves, as well as other elements of health inequalities as well. So it's something we're all very aware of, and it is having that blended, tailored service offering so that we do address it for everybody, and as you rightly say, particularly those people who need the care the most.
Okay, thank you. Before I bring on my next speaker, I would say just please do feel free to come back on it, because with the screen I can't see if you've got your hand up to come back anyway. So just come back. I've now got Councillor Allen.
Thank you, Chairman. General practice as the entry to the National Health Service is certainly probably very challenging at the moment, as is providing, healthcare to our communities as a whole, for all sorts of reasons. I personally do have some difficulty with and it's been raised by other colleagues on the committee, with the data, because it's so difficult to understand what it is that is being said in some parts, and what it actually means, I think, is even more important. So we don't really have an understanding of perhaps the overall extent of the issues, or indeed where the issues may actually lie. And it does seem as though that could be addressed with a greater view, should we say, of the data that is available, and a more accurate description of what that data is actually saying. So that's one thing, because I still don't know whether an appointment is a single event or a single activity is associated with a patient's particular concerns. Certainly, my evidence from using the GP system is that you frequently get a doctor saying, what are your symptoms? And then coming back saying, will you take a photograph, please, of whatever it is, and then eventually coming back and saying, perhaps you need to come into the surgery, and so that we can actually see it. Now, is that 3 appointments, or is that just one? Because it's all associated with one event from the patient's point of view. So it is very difficult to understand, what it is actually saying, the information. So I would ask our colleagues to see if they can actually use the data in a more helpful way for members of this committee, certainly, and perhaps generally as a way of explaining what the particular issues are. And without that, it's very difficult to actually say anything, to be honest. Apart from the fact, yes, everybody seems to be very, very busy, but whether key targets are being missed, or whether patients are being put at risk in terms of the number of patients doctors are seeing in a day, is actually of a genuine concern or not. It's very difficult to say without having better data than this.
I wonder if I could come back in on that, Councillor Macy.
Yes, of course.
Yes, I would entirely agree with you. Interestingly, this is the data you see, we've probably only been seeing for the last 12 to 18 months. It's a relatively new collection of information within Lincolnshire, and with my colleagues, and particularly with Reid and colleagues in the LMC, we are developing a much better way of capturing information that I think will not only help us understand what is happening, but will also help us, going back to the previous question in terms of health inequalities, help us understand where we have got those different health inequalities that we need to then respond to in a different way. We're building together with the local authority and the integrated care system a data set which we describe as the population health management data set, which will give us the integrated data that helps us see for any individual, and just by way of reassuring, this is all anonymous, so it is an activity data set rather than a personal data set. But what it helps us see is the contacts that are happening with the different parts of the system. That will then help us better understand those health inequalities and help us understand where we have got high levels of contacts, say in general practice, and the nature of those contacts, but also where those people in those communities are having high level contacts in other parts of our system. For example, in our acute trust, are they going to A&E? Are they having higher levels of non-elective treatments or high levels of elective treatments? And that will, I think, not only help us in terms of general practice and understanding the type of services that are required in primary care and general practice, but it will also help us understand the broader services that we need to provide in local communities that meet those community needs. And just again, by way of an example, you know, there is a lot of work at the moment in terms of community diagnostic centres that are really, really important for rapid access and links to supporting general practice, being able to get the feedback in terms of what's happening for an individual, and therefore initiate treatment quickly. We're looking very closely about how we build those in the communities, and that's across the whole of Lincolnshire. And so you're absolutely right, the data sets that we've got are limited, but there is a lot of work we're doing, not just in general practice, but across the wider integrated care system with yourselves in the local authority.
Thank you, Chairman. I'm very pleased to hear that there is this additional work taking place to try and make not better use of the data, but better quality data, so that better use can be made of it. My second question, Chairman, it's to do with the size of general practice and the amount of work that takes place, particularly with the support staff. The people doing the blood, taking the blood and sending the samples off, and all the way down to physiotherapy. I mean, certainly my general practice that I go to, it's got 3 partners, and it's got 3 locum GPs, and it's got something like about 18 to 20 support staff. So when we start looking at the data, and it's something I think that was mentioned in the BMJ fairly recently, or maybe one of the other reports from the College of General Practitioners. It's the amount of time that some of the doctors do spend on the sort of bureaucratic side of general practice, providing the data to a certain extent, maybe. And even though they might have practice managers, because the senior partner is responsible for the business to a great extent as a whole, they must spend quite a lot of time simply running the practice. Never mind attending all sorts of various external meetings associated with primary care delivery, in terms of training, in terms of meeting meeting colleagues in terms of providing, input at, high-powered external meetings. There must be a vast amount of time that general practitioners spend effectively running the primary care service without actually providing, doctoring, should we say, as far as the patient sees it. And perhaps that's something that ought to be looked at and considered within these data figures, because that will put a lot of pressure in terms of providing the services that the community is expecting, if the doctors aren't there to actually do it, but are doing other important things, equally important things perhaps from their perspective and from the NHS's perspective.
I'm sure Reader wants to come back on that. He's just trying to get himself off mute, I can see.
Yeah, sorry, apologies. My mouse decided to temporarily pause there. No, really good point, and I think it's something that echoes across general practice. So, rightfully, our patients have an image of the GPs in their practices and the other staff being there and doing a clinical appointment for them. But over the years, certainly the level of administrative tasks and managerial tasks within any practice, and you're quite right, external meetings as well have increased. And I think some of that clearly was done to improve and drive up positive health outcomes for patients in terms of focusing work onto certain areas and certain disease cohorts that really needed that intensive input by general practice. So I think some of those should be welcome, but over the years it's expanded, and yes, there is a lot of work that goes on to say tick box, shall we say, but there is lots of that work that is really, really important, but it's taking clinicians away from seeing patients. Now, I'd like to think, although I feel very old and my hair is greying extremely rapidly, that I've been around a few years now, so I don't know what it was like many years ago, but I'm quite confident there was a lot less paperwork to do. And a lot less checks to make from an administrative point of view, and that patients therefore did have more time. And I think you're quite right, patients won't necessarily see that that's what their GPs and other staff members are doing. So if they are struggling to get an appointment and they're frustrated, it might be partly because we're doing all of those things. So I think it is really important about if there are other things that doctors and other team members within practices are doing, that it's really worthwhile, it's focused, and it's not repeating things unnecessarily, so that we can optimise the time that we've got to care for patients directly.
And if I can just build on what Dr. Baker was saying, I think it is extremely important, and part of the work we're doing with Reed and colleagues is making sure that whenever we do something from an integrated care system perspective, what we're not doing is putting unnecessarily bureaucracy in terms of information returns. Obviously, we've got a role in terms of stewardship and making sure that we're achieving the outcomes for patients, but we work very closely to be practical and make sure that the information we gather, we're utilising the systems that clinicians will need to use to draw that information out. Again, that's activity information. It's not about personal data, but I think it does help to reduce that bureaucracy. The other thing that we are doing is making sure that we build professional networks. We've referenced about the wider multidisciplinary team, and that is fantastic, and it does start to bring new skills into primary care. But those colleagues all need that professional supervision, that support, and often that was falling to the GP to provide that. And what we're doing is working with, again, the LMC and the Lincolnshire Training Hub to develop those professional networks so that we have that sort of like wraparound professional support that will not only provide assurance in terms of the clinical contact, but also will support recruitment and retention of staff working across primary care and primary care networks. And then within that, particularly for general practice and GPs, we've also developed a number of things in Lincolnshire, the first 5 being one of them, that again are targeted at building those professional networks. And I think this is a change from practices being expected to do everything to how can we work together more efficiently and more effectively, so that practices do the things that only they can do, but we can build the infrastructure to support them, so that clinicians can be doing what clinicians want to do, which is treating patients.
Okay, thank you. Councillor Cleaver.
Thank you, Mr. Chairman. I have 3 points, if I may. First of all, the data set that NHS Digital has published on appointments, I've looked at the September ones, very comprehensive. And the thing that jumps out of the page at you is that in Lincolnshire, of all the appointments with GP practices, only 35% of GP appointments are actually with a GP, whereas 60% of appointments are actually with additional roles staff, and 5% are unknown. That actually is that 35% of GPs appointments actually being with a GP is the lowest in England. Now, compared, for example, to a 59% in most of London. And I think I'm concerned, sorry, two things. Interestingly, that yet, so we've got the lowest proportion of GP appointments with actually a GP, the highest, therefore, by inference, with additional role staff, and yet the additional roles budget is underspent and we haven't recruited all the staff, which is interesting. I'd appreciate your comments on that. And more importantly, because we are at one extreme of the spectrum here in Lincolnshire, do you think that the LMC and the ICB have done enough to reassure the public that being at one end of the spectrum isn't compromising patient care? Second question, on enhanced hours, are all PCNs in Lincolnshire actually operating the enhanced hour requirement of the NHS now in full? I believe it was supposed to have been brought in on the 1st of October. Are they all operating it in full? And if not, what measures the ICB taken where this is not the case? And finally, and I appreciate that this isn't related to the report, but it is an issue of public concern. Can you just let the committee know if there is any expected effect of industrial action by nurses on the GP service in Lincolnshire? Thank you.
Reid, I don't know if you want to come back on the GP coverage and then I can cover the enhanced hours.
Thanks, Sarah Jane. Yeah, thanks for your queries. We'll cover them between us, hopefully. So in terms of the data set, I think, again, Sarah Jane might be better explaining some elements of the data, as I've already mentioned for why. But I think what we might find is it's a twofold thing here. One might be going back to Sarah Jane's point about how the data is actually captured. So are we appropriately capturing the data of who is seen by whom? And that's what some of the work we're doing with the ICB is about, making sure that actually if a patient has seen me as a GP, has it been captured as me as a GP? Are we confident that that is the case? And I'm not sure we are at this stage. So I think there might be a data discrepancy there. I think the other element that is likely to affect it is actually the number of GPs in Lincolnshire compared to somewhere like a large population centre like London, as per your example, because we know obviously recruitment and retention is generally more difficult in more rural areas and coastal areas. So you tend to have a higher population density of GPs in those large conurbations of population. So I think it might be a twofold effect there. And I think the overall picture is we've, as we know, as a national picture, we've moved to more of an MDT approach because of GP, particularly workforce shortages. So what we've maybe seen in Lincolnshire is more adoption of those ARS roles, even though, as you rightly say, we've not fully utilised that budget, which is a frustration for general practice as well, because we'd love to have all those extra colleagues in supporting us. So I think you might see that we've accelerated the use of the ARS staff, which may again just skew the data a little bit. In terms of have we as an LMC and the ICB done enough, I think you said, to highlight and protect patients. I think what I can say is we're working extremely hard, both in general practice and from the ICB perspective, to optimise services and support our colleagues, to support our patients. I think, bearing in mind what I just said about the data set, I'm not convinced that data set is accurate as we'd like it to be. And I don't think there's a risk in Lincolnshire above and beyond any other area of the country currently in terms of risk to patients. I think everywhere is working extremely hard with a lot of demand, and we're trying to be as safe and high quality for patients as we possibly can within those confines. And we want more colleagues on board, including those on our staff, to support patients. Forgive me, I've forgotten what your other points were. Enhanced access, I think Sarah Jane will be able to give you the details better about that. From my perspective, I think everywhere in Lincolnshire is providing that service. I think what I would say, and Sarah Jane may correct me, is they aren't necessarily fully utilised. They're all offered, but what we tend to see is patients, although they want access that's timely for them and convenient for them, it doesn't necessarily mean that all those appointments will be taken by patients, because sometimes at the weekend they want to go and do something else because they've been working hard all week. And to be fair, to a degree, because of things like online consultation, working age patients who wouldn't necessarily have been able to contact their GP practice at 8 a.m. on the phone have got access now. So I think we're just anecdotally, I'm seeing less patients who are finding that challenging. But Sarah Jane will have better information on the data.
Yeah, no, thank you, Reid. And just to build on what Reid was saying, in terms of the clinical service, as you will see in my report, we rely on the independent assessment by the CQC, and I know you've got a report later in terms of one of the practices, but 74 practices out of 82 are identified as being either good or outstanding, and that gives us a high degree of confidence that they have the appropriate arrangements in place to make sure that the treatment being provided is being provided by the right person. And I think increasingly, as Dr. Baker has explained, we are seeing colleagues working as part of a multidisciplinary team. And what that means is that whoever has the contact with the patient does have access to that range of clinicians, including the GP, that can provide that intervention if somebody else assessing the patient feels that the GP is needed. And there's some great examples across the county of where that multidisciplinary team working is improving the support to patients. So particularly for patients with complicated needs, the frail, elderly, where a lot of the time the support they require isn't just the medical, which would be the expertise of the GP, but maybe more around the therapeutic or the medicines review, which are actually the expertise of other members of the team. And what we're seeing is that holistic care being coordinated by a clinical nurse specialist or a clinical therapy specialist is really enhancing that holistic support. And that means that the GP isn't trying to coordinate all of that intervention. Those individuals are getting quite bespoke services, but the GP, if required, will then be contacted. Normally, will be able to respond on the day, do the medical intervention, review the medication, or even go and do a home visit for those individuals. But that is the development, I think, that we will see increasingly as the multidisciplinary team develops. We are aware, though, that Lincolnshire, in terms of GPs, is lower than the national average, and that if you look at our percentage, we do have a higher percentage than elsewhere in the country of other healthcare professionals. And we are working very, very closely with the Training Hub, Health Education England, the university particularly, to make sure that we develop a range of career opportunities so that younger people that come and train with us actually want to stay with us, which is really, really important. And we can see where we've got strong training practices, the positive impact that has on recruitment. We're also working with colleagues at the other end of their career and encouraging them perhaps to stay in practice by being more flexible in terms of the type of roles that they can take on. So for some colleagues, they do want to move away from the partnerships as they're moving into retirement age, but they actually quite like clinical work. So we're looking at how we can develop that. But in terms of clinical care and clinical safety, I can absolutely be confident, both from my own contacts with practices, but also from the independent review, that the clinical care is good and strong. And where there are practices that need that additional support, again, my team and colleagues who will talk to you later provide very bespoke support, and the LMC also have a team that provide bespoke support to those practices. So there will always be practices that, for whatever reason, will be struggling at any point in time, but we've got a very well tested formula of the support that we provide to them. In terms of the enhanced hours that you asked, I can confirm that we have complete coverage across Lincolnshire. But again, I would highlight what Dr. Baker has said, that those appointments don't get fully utilised. So we need to keep a close monitoring of that, because this is the same workforce, and what we're doing is providing overextended hours, and we've heard about the pressure and some of the difficulties people have accessing appointments. If we've then got periods of time that we've commissioned that aren't being fully utilised, then we need to be open to perhaps reconfiguring that so that we get that capacity in the right place. And then your final question, which was with regards to the industrial action, I'm afraid I can't answer that at this point in time in terms of what the impact will be. Inevitably, there will be nurses working within general practice who may decide that they want to partake in the industrial action. And as with other colleagues, we will monitor that. My colleague Terry Vine, I can see, has just put his hand up. He might be a little closer to this with his nursing hat. So Terry, can I invite you in? You're on mute, Terry.
Not a great start. So thank you, Sarah Jane. So I'm Terry Vine, Deputy Director of Nursing and Quality at Lincolnshire Integrated Care Board. So the Royal College of Nursing are only balloting nurses that are directly employed by the NHS through Agenda for Change contracts. So it won't affect general practice unless we have general practices that are run by an NHS organisation. I think there is only one that is run by LCHS in Lincolnshire. So it is not expected to have any impact at all on general practice. And also, not all nurses will be members of the Royal College of Nursing. It is only the Royal College of Nursing, and there will be other union and professional organisation that nurses will be members of that won't be part of this proposed industrial action. I know that we're expecting an announcement today of what the decision, the outcome of the ballot will be, but I'm not expecting it to have any impact on general practice.
Thank you, Terry. That's really helpful.
Thank you for all your answers. Just to underline what my question was regarding public confidence in the GP appointments, my concern, and you really haven't quite directly answered the question, do you think you're doing enough to make sure that there is good public understanding and public confidence in the fact that the lower proportion of people being able to actually see and have an appointment with their GP isn't undermining public confidence? People understand that and understand exactly what's going on, why they can't always get an appointment with their GP, because that's not what's coming through to me. So again, it's not a question of the fact that we're questioning the integrity of the system. We're questioning whether there is a proper public understanding and whether you're doing enough to make sure that public understanding is there. Secondly, in terms of enhanced hours, I have anecdotal evidence that, and it is only anecdotal, that that's not being operated in full across all PCNs. I'll deal that with. I'll mention that to you outside the meeting. But just a thought. I mean, would the ICB consider asking and requesting that all GP practices do publish how they are conforming to the enhanced hours on their website? because it's certainly the case that my GP practice has got nothing about enhanced hours on its website. So I think, again, there's a question of public not being properly informed on it, potentially. Thank you.
Thank you. And yes, I will pick up with you if you think there's an area that isn't fully providing that. I think that we have got a lot of work to do in terms of the communication with the general public to help them understand that the primary care service offer is very, very different to the one that perhaps many of us grew up with. I don't think we can ever stop doing that. But when you say, do I think we are we working on that? Yes, we are absolutely working on it. And my colleague Kev Gibson is actually connected with this event so that we can hear the feedback and make sure that we absorb and take that learning. I think we have got a lot of work to do about helping people understand the full extent of the range of services that are now available to support people right through being able to get symptom check in terms of on your NHS app. Which again, going back to the previous comment about health inequalities, we know that isn't for everybody, but for a lot of people, using the NHS app is a really, really useful tool for symptom checking or ordering repeat prescriptions, and that reduces some of the footfall through to practices, right through to this, as I've described, a very, very different way of working for some of our more complex patients with more complex needs who need the multidisciplinary team. I think we've got a long way to do to help people to understand that. And it's something that we continue to do, and will, I think as well, we want to open up the discussion with the general public to understand what information is available and how we might adapt that to make it more meaningful for people. But I think at different points in your life, you need different things, and that's something we've got to understand. If you're a mum with a baby, that's very different to I'm in my 85th year and I need some particular support with my complex needs. So I think we've got a lot of work to do on that. Reid?
Thanks, Sarah Jane. Yeah, I just wanted to build on what Sarah Jane was saying. I think exactly right. I agree. There is a lot of work to be done. I think I'm just going to reflect back on what I was saying earlier about meetings for myself and other clinical colleagues, making them count. And I think we get a lot of information as clinicians, emails coming through, and I'm sure everybody in the meeting today does. But it's about getting that message to the patients, the important messages between all the other messages they get in every media format that it comes at them. So I think that's really one of the key things, as well as getting the information right, getting the information that's most important front and centre for patients. So that is something that is extensively being worked on currently. What I'd also say is I think more than ever now, we've got more of a two-way flow of communication with general practice in our patients. And that's going back to one of the positives I said about technological advances. So a lot of practices now have Facebook sites or the social media sites, and they can put information real time on there for patients, and that helps, because I think having some transparency and patients understanding what's going on in a practice really helps to sort of have that two-way understanding and support. So while there's still work to do on that as well, I think it's a positive step forward that we've got that for patients.
And just to come back to your question about enhanced access, my colleague Sarah Starbuck is also on the call and has been leading on the enhanced access. Sarah, I don't know if you just want to come in and say some of the work that you will be doing around the social media and the information on websites.
Yeah, of course. I'm Sarah Starbuck, Head of Transformation and Delivery for the ICB. So I've been leading on this, supported by colleagues, but also LMC colleagues, in terms of reviewing the enhanced access arrangements. We will be making sure this is well publicised. It's part of our winter plans. So we are promoting the access. We will make sure it's on all of the practice websites, it's on all the social media channels, and we publicise through other routes as we've done for other services. So it is a priority for us. We have given PCNs a couple of weeks just to get the service embedded. It did only begin in its new format on the 1st of October, and we are now working to review it and get it promoted. As Sarah Jane said, utilisation is still far from 100%. We want to promote this and encourage use for patients because it is evening and weekend offer, which we do see good take up, but we don't see full take up for. So we want to promote that over the coming weeks.
Okay, thank you. I have 4 speakers left still, so I'm just a little bit cautious. We seem to be delving into the next paper already, but I'm sure that'll reduce questions on the next one. Councillor Thompson.
Thank you very much, Chairman. I think today's agenda regarding general practice highlights some of the inconsistencies, and it has been referred that 70% of practices are rated in Lincolnshire are rated good or outstanding. That means 30% are not rated in those categories. I was privileged yesterday to spend some time with a practice manager, and I would have to say that this was outside Lincolnshire, but the collection of data and compliance with I'd say instructions from above was causing issues and having problems with the impact on service provision. So I just wonder how much this goes down to practice level. And secondly, the outgoing RCGP president has commented on the continuity of care provided by general practices, by the ever-expansion primary care networks and so on in extended practices. And I just wonder what the views are on that aspect of general practice, which used to, I know it's now back to general practice. At one time it was family practice, and the GPs actually knew the patients. Any views on that, please? Thank you.
Yes, if I can come back in first of all, I'm not sure whether my maths are correct, but if I do my maths, I think it's 90% of practices in Lincolnshire are actually rated good or outstanding, as opposed to the 70%. So that's I think important to note that it's 74 out of 82 are rated good or outstanding. In terms of the other elements, in terms of the bureaucracy, there are some things that are within the gift of the ICB, and as I referenced earlier, we do everything we can to minimise the bureaucracy. There are other elements that are national requirements, and there's very little that we can do, although we obviously work very closely to influence NHS colleagues to think about what they are asking practices to do. But inevitably, there will be some areas of feedback that's not within our gift. Reid?
Thanks, Sarah Jane. Yeah. So I was going to talk about those numbers as well, but I think it just the way it's displayed, it makes you potentially think it's a percentage rather than a finite number of practices. But yes, 90%. In terms of the thing that I picked up primarily from your queries was there's continuity, and in general practice we acknowledge the continuity actually is crucial. So I've not got the biggest practice in the world, but I know an awful lot of my patients. I know their name. Weirdly, I often know roughly their address and number, and I know what they come to see me about. And that's one of the great things, because if Mrs. Smith comes in to see me and she's not quite as she normally is when I've seen her, I'm picking up on things. So continuity is crucial. I know all the interlacing medical conditions she's got and what effect something might have on her that she's experiencing now, or a treatment I might give her. So we really are passionate about that in general practice. I think what makes it more complex, and forgive me, I'm going to try and bring some strands together and I'll try and get them all into what I'm trying to say. We have this continuity that we'd all love to continue, and I think it really should, and we should be passionate about that forever in general practice. But as we've talked about, we have an increased demand, and a lot of that demand, as I said in my report, was this single episodic care for patients who are normally fit and well, be that with minor viral self-limiting illnesses, etc. And that demand is being driven for a couple of reasons. the world is more stressful and difficult. People are more worried about their healthcare. And we've driven it nationally with media, etc., to go and get advice about your healthcare. What we haven't got is that big swell of capacity to meet that. So we're kind of juggling this continuity that we all know is really, really important, while trying to address the increased demand in that cohort of patients who wouldn't maybe have traditionally come to contact us. Because general practice is more accessible than ever, and I know people, as we said, do struggle to get appointments at times, but with things like online consultation tools, patients get a really quick piece of advice from their GP practice that they might have, before Google, spoken to a family member about, or they might have Googled to get a bit of information about. So they get that robust advice really quickly. So it's about that. How do we address all of these things with the capacity we've got, with the workforce we've got, with the infrastructure we've got, and give that high quality care to patients? Now, the fuller stock take, which I've talked about in my report, and many of you may be aware of, talks about how do we match up that continuity and that episodic same day treatment. And that really is something that we've started working on within Lincolnshire, and I'm sure nationally as well. But it is that really tricky balance, but I completely agree, continuity is really important. And I feel much more satisfied at the end of the day as GP if I've dealt with Mrs. Smith, forgive me for using the name Mrs. Smith multiple times, and I've made a real difference to her, because again, next time she comes to see me, hopefully that's going to be a positive outcome as well.
Thank you very much.
Thank you. I've got Councillor Loughagan next.
Thank you, Chair. I have wanting to thank you for your report, and I have the greatest respect for staff in PCNs who I'm sure are working very hard, and particular respect for the way the COVID vaccination's been rolled out. It's been very helpful. However, I think the figures in this report are so far from what people's experience as reported to me and my own experience are. I report back to the Policy Scrutiny Committee of the City of Lincoln Council, and I'm sure the other councillors on that committee will say the same thing when I report back about this. So I think the communications problem is quite a bad one, and that the detail, as Councillor Allen pointed out in this report, is not sufficient for us to know the answers to the questions that people have about access to GPs. So that's more of a comment. My question is, do PCNs get provided with data on the number of people who attend A&E departments or urgent care centres because they are saying they don't have access to a GP? Thank you.
Thank you. And as I explained earlier, I think there is much more work we need to do in terms of the detail of the data to answer some of the specific questions that people are raising with us. And I think it's also true to say that there is different experiences across the county, and different parts of the communities not only have different needs, but they have different service provisions. So we do work very hard to get that visibility. In terms of the primary care networks, as with the other areas, we're doing a lot of work to really strengthen the data available. The area that we are most advanced is with regards to the enhanced health and care homes, which has been something that PCNs have been working to develop for quite a considerable amount of time now. And this is very much around a different type of relationship between primary care and care homes, where there is continuity in terms of a multidisciplinary team. And in a lot of instances, a care home is supported by one practice. So again, you get strength and continuity. We now have a very comprehensive set of data that we can provide to PCNs that enables them to see right from what's the contact that they're having with the care homes, through to if an ambulance has been called, whether the ambulance has actually had to convey the person to hospital, or whether they've been able to support the patient on site. Similarly, the other range of services that we've got in the community. So there's a service called Urgent Care Response, which is not EMAS, it's a different service, but it actually enables people to get that urgent care response. So here and now, the PCNs are starting to receive the data around the different elements of services that we're developing. It does give them that visibility. Have we got it for everything? No, we haven't. Have we got a really good blueprint that we can now use to support PCNs have that visibility? Yes, we have. And my colleagues presented that to the PCN CDs a couple of weeks ago so that they can see that, and presented it to the PCN managers yesterday. So this is all part of the work that we're doing to help everybody better understand the needs of patients in a local community, how we're responding to that. But more importantly, what are the improvements we need to make, and how do we make those improvements that are relevant and appropriate for that particular community? So is it a job completed? No. Is it a job we're well underway with? Yes.
I'm still a little bit confused about the answer to the question about whether PCNs are provided with data when a patient attends A&E or an urgent care centre and says they have gone there because they couldn't get access to a GP.
So in terms of the data around whether a patient themselves says I've come to A&E because I can't get an appointment with a GP, that would not be routinely recorded. Healthwatch colleagues, I think Liz is in the room, are about to do a survey which will be in A&E, which will give us a much better understanding of whether a patient has gone to an urgent treatment centre or A&E because they can't get an appointment with their GP practice, or whether they've gone because actually the urgent treatment centre is more appropriate to their needs, or dare I say, more convenient to their lifestyle, because for some people that service being available is more convenient for them. So the audit that Healthwatch colleagues are about to start will provide us with that level of detail. In terms of a general practice, Reid may be able to just correct me if I get this wrong, but if a patient does attend either a UTC, an urgent treatment centre or A&E, the practice would be aware of that because they would get the clinical information about that.
Yeah, I think Sarah Jane's quite right. We do get a report if a patient attends one of those venues for input. And I would agree. I think the reasons people present to those UTCs and A&Es varies, and you're quite right. Appropriate presentation for an accident or an emergency at A&E and urgent treatment centres for a wide range of potentially less serious conditions. And I think what Sarah Jane says is quite right. Sometimes it is more convenient for patients to go there because they can just turn up. Whereas obviously with general practice, they would tend to contact us through whichever medium they would normally contact us to ask for advice or treatment. And we find that in centres where there is an urgent treatment centre or an accident emergency very locally, patients are more likely to present. And I think, again, the data would be really useful in terms of if a patient contacts my practice, but then for some reason doesn't see us at the practice, doesn't get help from us at the practice, and attends one of those centres, that we can see why that happens. And I think one thing to remark is that perception has changed, I think, in terms of, again, societal expectations of input from health services. So if we think back a good few years ago, we might be waiting several weeks for an appointment, whereas now most things, as per the data, are dealt with on the same days, and almost everything within a couple of weeks. And most of those people that wait a couple of weeks is because there's a patient request for it to be a couple of weeks, be it a blood test, etc. But what we might find is sometimes patients contact us at 8 a.m. on a Tuesday morning, and I say I can see you at 3 o'clock or whatever the time may be, but they might feel for convenience purposes that they want to be seen before that, and therefore may attend a UTC or A&E. And the data will be really useful to see what that flow is, and see, again, as part of this wider population health management, what we can do to help patients navigate that system.
Okay, thank you. Before I bring on the next speaker, I must just say I'm completely baffled with this item. We're told that, you know, our GPs are seeing more appointments now than ever. Then we're told the data actually doesn't back this up. It just seems incredibly baffling, the questions and answers we're getting. 9 times out of 10 as well, I do feel that, you know, I've heard in several cases where our GP practices are actively telling people to go to UTC, so I'm sure they've got the data there on that as well.
Sorry, Carl. Sorry, I think the data does demonstrate that primary care are seeing a significantly more patients than they were in 1920. I think there are incidents, and we get those incidents reported to us, where patients have been advised to go to A&E, and we investigate those. So I know that because we're currently investigating a couple that have been referred to me in the last couple of days. So I don't think there is any doubt from the data that we're seeing that the demand for primary care is increasing. What I think we've been asked throughout this session is the detail beneath that, and that is the area where we need to do more work. I think we also need to make sure that in terms of the total activity that is happening in primary care, we have the collection of the total activity. And again, we don't have that at the moment. So, but I think there is no doubt that primary care are seeing an additional 25% more than they were in 1920. And we need to understand what, in addition to that, they are also seeing.
Okay, thank you. I've got Councillor Smith next.
Thank you, Chairman. Apologies I was late. Before I go on to my question, if I may, to back your point up, certainly around UTCs, I am not aware of anybody that goes to a UTC for convenience. That's if you've got one. My residents don't. So we don't have, when we have GPs, go to a UTC. We don't have one in my division, so it is literally the GP or A&E. My question, Chairman, actually goes back to Councillor Cleaver. I'm not surprised that we have the lowest level of GPs. This goes back to a campaign for a very long time around requiring rural waiting, which we still haven't got. But actually, it goes back on to your announcements, Chairman, around the review that the House of Commons did, and Section 5 particularly, and it says that GPs and patients should have a relationship not the same as an Uber driver. Well, actually, Chairman, you actually have a better relationship in my experience, because you can actually book one rather than being told, no, you have to go and ring me again and try and see me tomorrow. Well, for a working age population, that simply isn't viable. And yes, you have online, you have all these things, but actually what people want, as my MP, Sir Edward Lee, said in the House of Commons very recently, they want, as Councillor Thompson put it very eloquently, a family practice where you actually see the same GP and you know who you're seeing and you actually can see them face to face, because actually 9 times out of 10 that's actually what people want, that's what people expect. There is a systemic problem, because we know this because when we had EMAS here, we were, shall we say, quite firm around their attendance times to capped 2 and below instances. And the reason their times are the way they are, Chairman, is because much like the fire service around co-responding and things like that, the phone is always there and they will always answer it and you will always get seen. That is the problem. I will go further than Councillor Cleaver around, he said that the system, no one's sort of questioning the system. I am questioning that system because I don't think it's functioning anymore. How you fix that, we'd need to have a conversation around, but I don't think the system as it stands, Chairman, is working. And our residents in conversations we have back that up. The presentation around EMAS we've had and handover backs that up around the level of people who are going to A&E or who they're having to see, hear and treat, when actually, if they'd have been able to get to primary care, you wouldn't have actually needed to call EMAS out in the first place. There is a systemic problem. Now, how we fix that, I don't know, but I don't know of anybody that goes to a UTC to convenience. In my experience, there may be some that do, but I don't know of any. I think there is a systemic problem in general practice, and we've already alluded to in previous presentations around the GP contract, and I think whether people like it or not, I think that's where it starts, and Councillor Thompson can explain that far more eloquently than I with his learned experience. But I think that is when it started, and it certainly is from my experience and people I know, that is when their problems started. And until we have a very frank conversation around access to primary care and actually access to a GP, because that's the important point. It's okay, some things you don't need a GP for. So if I'm going to have bloods taken, I don't need to go and see the GP to get blood. There are certain things actually I need to see a GP for. But when you get the receptionist and you're asked 1,000,001 questions, that will put some people off ever trying to contact the GP again unless they're in screaming agony because they don't want to be interrogated over what's quite a private matter over the phone to somebody who they know isn't, shall we say, as medically qualified as a GP, because I'm aware they have some medical background. But there is a systemic problem, and I think we need to have a serious conversation with our representatives as members of Parliament and also around the NHS in general about how we tackle this, because at the minute the system's broken as far as I'm concerned.
If I can come in there, I wasn't quite sure of the exact question. I kind of get a feeling for the frustrations and the experiences that you've kind of outlined. I think I would agree. It does need to be discussed locally, regionally, nationally, in terms of how a model can work for everybody, the patient and everybody working within the system, and not just general practice, but the wider system. And that is part of what the creation of integrated care systems across the country a few months ago looks at addressing. What I would say about general practice in terms of access, there never has been more access and more avenues of access. And you're right, you don't need to see a GP for everything. And sometimes I'd like to think I'm quite good with musculoskeletal problems. However, our first contact physiotherapist, who's an expert and only deals with that sort of thing, is better to have a consultation with than myself. And I'll be open with my patients that is the case. So when we have a reduced GP workforce, as we do, using all those other experts from an MDT team is crucially important. We still, as a society as a whole, imagine we're going to see a GP, and because that's the model we've always had historically. And that, again, is a reflection of things changing. But I agree, your GP wants to see you. They want to treat you. They want the help of all those other colleagues as well. If we had lots more GPs, then patients would be more likely to see their same GP every single time. But it is really challenging, and we share your frustration. We'd like a lot more GPs in Lincolnshire, not at the replacement of all our staff, but as another booster to the workforce that can help our population. So I do share those, and I think the complex interweaving of how systems and providers such as EMAS, general practice, and the acute sector interact is one of the crucial pinch points in the system. And subsequently at the other end of the hospital care as well, in terms of social care and what provision we've got for our population in the social care sector, because each section has an effect on the other, and we want it as streamlined and effective as possible. So I would agree it needs to be raised nationally, but what I will say is general practice is working incredibly hard at higher levels than ever with a workforce crisis, but we do share your frustrations.
Thank you. I think I'd just add on to that. I think it depends where you live. I'll bring in Councillor Chalmers now, please.
Smoothly done, Councillor Macy, because that's exactly what I would like to say. First off, I think we're overcomplicating things. People just want to see a GP, full stop, and they just want to be able to pick up the phone. Having said that, I have had one of my residents contact me because he doesn't have a phone. He's been denied access to GP care, which is abysmal. It is disgusting, and it made me feel sick that somebody that has no money is being denied actual care by the NHS because he can't use the phone to receive or make a call to book an appointment. He stood in reception, was sent away. That is not acceptable on any level. Where we are, I'm at Boston in Lincolnshire, and I speak about Boston, not the heart of Boston. Boston Town Centre has got both mobile phone signal and internet signal. I live 3 miles out. I can't get phone signal or internet signal. I have a condition of conditioned anxious behaviours if I ever need to access care, and I tell you, my leg would need to be falling off before I wanted to see a GP. However, I am a mum with a baby, and it means I have to contact you, and it fills me with dread. The last time I had to, I point blank refused and made my partner do it. The outcome of that, was that it was as complicated as I expected it to be. We picked up the phone, we went through to an answering machine which said that the GP was closed for the day for training. I was to call 111. The 111 system took my partner 25 minutes. He was sat next to me, for them to then end the call with, "Oh, your son needs to see a GP." The GP then was admitted, they went into a system, and the 111 system booked a GP to call our home, which is a mobile phone signal, but because we were really located, he started the conversation with, "Your line isn't very clear, can you speak to me from somewhere else?" Well, the answer is no. And they pressed the button to say they were on a training day by mistake, and actually we should have been able to just speak to a receptionist. With all of that in mind, if you live and work in rural Lincolnshire, you might not have phone access, but you also don't have internet access. If you don't have Wi-Fi, there is no way that you can just jump online. And I've had, again, residents contact me that they've tried to book an appointment for their daughter. They work in a factory in the middle of nowhere. You have to ring at 8 o'clock, but they work a shift that starts at 6 a.m. We are making the NHS completely inaccessible to our residents, and it gives me goosebumps. It is horrific to get an appointment. Whoever says, let's open up internet, let's open up extra phones, let's just go back to basics where people can walk in and say, "I'm desperately poorly, my child is sick, can I come back in an hour? Can you see me at 3? The phone signal's bad. Please work with me," rather than sending me away to use another system. It's all overcomplicated, completely overcomplicated. And it isn't easy unless you're in a city or you have access to city amenities, such as walk-in centres, blah, blah. All these things you've mentioned that I know nothing about. Moving on from that, and I'm not going to harp on about this because it has been mentioned, but the locum thing, I see more of a problem than just continuity. Locum doctors are putting stress on other areas. They're seeing a patient. Dr. Baker, you referred to Mrs. Smith, so I quite like that name. We're going to run with Mrs. Smith. You might see her every other week and you're on holiday. She's a bit of a hypochondriac and there's nothing really wrong with her. She gets to see the locum and he's sent her off for tests at the hospital, which is a drain on other services. On top of that, that locum is not learning the skills of seeing through and being able to identify rare or unusual diseases because they're there for such a short period of time. So in 20 years' time, they won't have the 20 years experience that you had at that same point in your career because they're only doing part of a job, which is a bigger problem, which is going to cost the NHS more in the long run. So we need to look at the bigger picture rather than just the immediate. We're literally, in medical terms, we're looking at the cause of the problem rather than just putting a plaster on a symptom. But please promise me that you will come out of this meeting and make it aware that no GP surgery in anywhere in Lincolnshire should turn a patient away for turning up and not having phone access, because that is just not acceptable.
I'm very sorry to hear about that experience. That shouldn't be the case at all. And I will ask Simon to speak to you so that I can get the specific details and we can follow that up. It is absolutely vitally important to myself, my colleagues, Dr. Baker, that we do support people and recognise that there are people live with different sets of circumstances, and some people will not have phones and some people will not have internet, and we need to make the healthcare service accessible to them. So I would be very pleased to investigate that further. If you could pass the information to Simon, I will do that. And in terms of the locum workforce and your final point, I think it reflects and is consistent with your colleague in terms of we are, I think, in a place where we do need to have a conversation around what is the healthcare service offer, and this is something that I think Dr. Baker and myself would both concur with, in terms of what works in a rural community is not the same as what would work in the centre of London, and we need to make sure that the services that we are able to offer reflect the rurality of our community, and that is a conversation that, as an integrated care board, we're very, very keen to have, so that we can start to develop those services and look at the local needs, taking account exactly what you've said in terms of poor mobile signals, poor internet, different personal circumstances.
Yeah, and if I could build on that as well. Thank you for your comments. I think it was really interesting, although we don't like to hear some of the things you were saying, but interesting to hear some of those concerns that you have. I think the things that kind of stood out for me were, I would agree completely in terms of infrastructure being an issue in the county. It's a personal frustration of mine for my patients, because again, a lot of my patients live in quite rural areas of Lincolnshire, but also personally, I can rarely get a mobile signal, and I don't live that far from Lincoln, about 8 miles away. And in this day and age, that seems strange. I mean, I have access to a mobile phone, which puts me in a much better position than a lot of our patients who don't have a mobile phone, or in the case of your patient, doesn't have any phone at all. I agree with Sarah Jane that I would not want to hear of a patient not being able to access services because they don't have a phone or can't operate a phone. So a practice, I would hope, would do everything they could, put special notes on that patient's record to say they don't have access to these modes of communication, and make reasonable adjustments for that patient. I think those things reflect, again, what we go back to in terms of the work around health inequalities that is going on, and will become a bigger and bigger part of what happens across Lincolnshire, to make sure that these cases aren't happening, not that we would want them to be happening in the first place. In terms of making it complex, it is complex, I agree. Healthcare is increasingly complex. As I said earlier, the world is increasingly complex as well. We do want it as simple as possible, but as we know, not one size fits all. So that's why there are these different modalities for people to contact us. Patients used to be frustrated if they had to queue outside a GP practice for half an hour before the doors open to get an appointment. So a lot of that queue has disappeared by the other modes in terms of online access, etc. But I would still hope that if patients walk into a practice that they want an appointment, and there is capacity for that appointment, of course, that is something that's done for them. And I think, I'm disappointed if that doesn't happen across the board. Particularly in terms of an unwell child, it's one of those things in general practice. If someone walks in with an unwell child, that pretty much, that needs sorting out. That needs seeing straight away and making sure that child's okay, or doing the necessary for that child if they are unwell. So I would hope practices would prioritise that, along with other groups who are significantly unwell when they walk in. In terms of locums, I agree. I think that to a degree that reflects the challenges for workforce, particularly in Lincolnshire. And I think the larger number of locums nationally as well reflects the pressures in general practice, in terms of these locums. Actually, a lot of them are highly skilled, very experienced GPs, and probably are really good at recognising those rare or serious diseases, and they've probably maybe worked for many, many years. But what they really like doing is seeing the patients. So as a locum, they're not going to have the same administrative workload that perhaps a salaried GP or a GP partner would have. So actually, they often are just doing more clinical work and are highly experienced. Yes, we'd love permanent staff to build that continuity that you talked about. And some practices do have locums that work for them on a long-term basis, so get to know the patients at that practice. But I agree, we'd love permanent staff. That's what would make the service more sustainable and hopefully a better experience for patients. But those locums are really crucial when we in the workforce difficulties that we have.
Okay, thank you. I've just got a couple of questions, and then I'm going to close down the debate and move on to the next item. So my first question is, on page 39, the report states that 54.6% of appointments are within 24 hours and 82.8% within 2 weeks. Can I ask, how is this monitored? As in my personal experience, you're not allowed to book an appointment in advance. In fact, you're advised to play the appointment lottery of ringing up at 8 in the morning, normally with all appointments gone by the time you finally get through.
I can come in first on that, Sarah Jane, if you like, although again, it's data, so you'll be excellent as ever with clarifying any points. So again, there is work to go on with the data, and I'm sure Sarah Jane will sort of talk about that. But going back to a point I made earlier, so particularly when we've moved to online consultation as the initial way of patients contacting, or a large proportion of patients contacting practices, a lot of those things can be dealt with on the same day, be that a straightforward query, or be that someone who just needs seeing that day and needs their chest examining to see if they've got a chest infection that needs antibiotics, for example. Then we have a cohort of patients who might contact me and I say, oh, your medications need reviewing, you need a blood test to make sure everything's going okay, and a blood pressure check, whatever that may be. But they don't need that there and then, they need it in a few weeks. So then they might be booked in 2, 3, 4 weeks later with the nurse or healthcare assistant or phlebotomist to do those blood tests. So some of the data will be around that because it's appropriate care at that point in time a few weeks down the line because they didn't need it there and then. So it's a bit about appointment planning and care planning. In terms of, you're sort of saying a lottery, I think, again, models vary in terms of how practices use telephone, online consultation, and people walking up to the desk to book appointments. And we know there are still challenges because there, again, going back to the point about capacity, there's a finite capacity with the workforce we have. So if everyone goes online and requests an appointment at 8 AM, as well as the people telephoning, etc., that capacity is going to be reached. But with this model that currently happens, most things are dealt with on the same day appropriately. You know, it's not infrequent, a patient will contact me, but they're not available to actually come and see me until a few days later. So I'll book them in to come and see me then. So there's these nuances that the data can't quite pick out at the moment, I think will be useful going forward. What I would say is, you know, it's not a perfect system, but as I alluded to earlier, sometimes patients were waiting weeks, sometimes multiple weeks, 6 weeks for a routine appointment in general practice. And maybe not full coverage, but as far as I'm aware, that's not the case across Lincolnshire anymore. Most things, as we see by the data, are dealt with on the same day. So patients are getting a more timely service, but we're having more demand for the same or even less capacity. So there are still waits involved, which is, I understand, frustrating, but we've got to work within those capacity constraints until we can hopefully find a solution to that with a greater workforce and system changes.
And I think just to build on that, I think it is fair to say that there is variation, and there are some practices that don't offer the same level of access or the support that we would expect, or that they actually would want to for whatever reason. And those are the practices that that are highlighted by the CQC, so that independent, but also by ourselves through our own quality visits, and those small numbers of practices do need some targeted support to actually look at what is happening, so that sadly the experience that that you're describing, Carl, where it feels like a lottery, isn't the case. But there are a small number of practices where there are clearly difficulties. And that is where myself, my quality colleagues, and the team from the LMC need to work with those practices to look at what's the systems and processes that they've got in place. What are their arrangements for managing their appointment scheduling and things like that? Because clearly it's not working. And when we see that when we see that there's poor access, we see that there's poor patient experience, those are the things where we need to work very closely with them as a practice to improve internally. And we need to understand whether there are other factors that as an ICB that we need to pay attention to, because some of these are within the practice themselves, some of them are in that wider community and the context, and it isn't there is a true interdependency with primary care and other parts of the health and social care system that impact on each other, which is why as an integrated care team, we're doing much more work around those relationships with the hospitals, EMAS and colleagues like that, because it's not they're not sort of like self-contained little bits of a healthcare service. They do all have an impact on each other.
Okay, thank you. And my final question, and I think most of this has been alluded to specifically, I would say, from Councillor Loughagan, but we have heard that general practices are striving to provide safe, timely and effective care. And the report has already alluded to that there are longer hospital backlogs, the same for ambulance response times, same with attendances at UTC, A&E, and the general public often saying they go there because they can't see the GPs. My question to you is, are GPs truly providing safe, timely and effective care? Because it certainly doesn't feel like it.
Obviously, you've just alluded to challenges with other parts of the healthcare system. As I've said, I think we are working incredibly hard, and I think everyone wants to provide a safe service. And this is somewhat where the challenge with capacity sits. In terms of, can I safely see 100 patients a day, or does it become unsafe at a certain point? So it's about providing high quality, safe care within the constraints of capacity and workforce, as I've alluded to already. The waiting lists for outpatient appointments, surgery, etc. in hospital, or even investigation in the first place when a GP has initiated an investigation pathway, are having an impact, as I alluded to in my report. Because we've always had waiting lists, but they've been exacerbated by the pandemic because of staff shortages in hospital. Obviously, sadly, we had an issue with arson in Lincoln County a while ago, which affected imaging services and infection control measures during the pandemic particularly. So that's increased that backlog. It makes it a challenge for general practice because those patients who might have been seen for their investigation or their outpatient appointment or their surgery are consulting appropriately with general practice because they're concerned or they've had a flare of their symptoms or they've not had their appointment yet. So that's adding to that demand workload within that capacity that I was talking about. So that does make it more of a challenge. It doesn't mean that general practice isn't working safely, because what we're doing is working at the possible capacity we've got as hard as we possibly can, and within that are those patients who are waiting for those hospital appointments, for example. Now, I think there's been more flow to UTCs, etc. But my understanding is in accident and emergency that there's less activity than there was historically going on. So perhaps there's not been that drive from general practice to accident and emergency, despite the 20+% increased activity in general practice. But that's going back to what Sarah Jane said about the complexity of how everything interacts. Nobody in general practice goes to work at the beginning of the day and wants to not help patients and work unsafely. We're all really passionate about that. And I think maybe that transparency that I talked about earlier will be helpful. Don't get me wrong, it doesn't give someone an appointment, but they can understand what we're trying to do for them with all these challenges before pandemic, during, and the ones we're going to face going forwards. So although I do understand that frustration, I really just must press home that general practice is working incredibly hard. And like any role, unless you're in that role, you don't see what's going on. And understandably, therefore, people are frustrated. But that's why I'm saying we need the support, because support, these system reviews, addressing health inequalities, looking at how the system works across Lincolnshire and reviewing those interactions and with all the different services in terms of acute sector, EMAS, general practice, etc., is how we're going to make things better for everybody. So although that doesn't answer the question for today of how we make things better, that's the blueprint for what we then do. But we are trying our utmost. I just want to emphasise that.
Okay, thank you. I mean, the only one thing I would say is we're certainly aware of 13-hour waits at A&E, so to say that there's not immense pressure or seems above average pressure on them does, again, seem quite confusing to be hearing. I will now move to a proposal anyway. Sarah Jane, I think we're going to have to move on, I'm afraid. Some of it will probably get picked up in your next paper anyway. So I'm going to thank Dr. Reid Baker from the Lincolnshire Local Medical Committee for his report and presentation. I'm going to propose that we note the developments in primary care, such as the increase in clinical pharmacists, first contact physiotherapists and occupational therapists, but to seek assurance that the ratio of appointments conducted by GPs as opposed to other clinicians in primary care is meeting the needs of the Lincolnshire patient, and to seek a further update in 6 months' time. Do I have a seconder for my proposal, please? Thank you, Councillor Loughagan. All those in favour, please show. Thank you. That's supported unanimously. Thank you. Okay, we'll move on to the next paper. I am just conscious of the time, but I'm fairly certain there will be some questions that are probably crossed over anyway. So we'll move on to agenda item 8, GP provision for NHS Lincolnshire Integrated Care Board. The item was circulated as part of the agenda pack on pages 43 to 50, and I'd like to welcome once again our presenters with Sarah Jane Mills, Director for Primary Care, Community and Social Value, and Nick Blake, Acting Programme Director, Integrated Primary Care and Communities. Sarah Jane, I think we've covered a lot, so if you just have a relatively quick through, because I'll take the paper as read and probably move quite quickly to questions. Thank you.
Yeah, so I was going to say exactly the same, Carl. I think we've covered quite a lot of the points that I would have drawn attention to. So I'm very happy just to move straight to questions.
Excellent, thank you very much. Do we have any questions? No, I will make a start and then I'll bring in Councillor Cleaver. I think, again, in part, you probably alluded to this in the previous paper, but recruitment is always a reason why it's increasingly difficult to see a GP, we're told. So what new and innovative ways are you looking to try and address this issue of recruitment?
Thank you. There's a number of different things that we're doing to recruit and retain across the wider primary care team, but specifically general practice. And that includes developing some very, very innovative fellowships in terms of these are for GPs that are new to practice, that provide them with the additional support and I suppose range of opportunities to develop areas of interest, which we have seen has been very attractive. In those, and I've put them in the paper, we have got 10 new GP new to practice. That number is set to increase, but specifically, and I think linking back to the previous discussions, GP fellowships in health inequalities, digital, and the plans to introduce a joint research fellow with the university. So very focused on appointing people or attracting people to come to Lincolnshire so that they can continue to develop their personal career opportunities. In addition, really investing in that the first 5 group and building the network to provide them with the support. 108 GPs working in that space at the moment, and that's due to be extended. This has been something that has been focused around the first 5 years, but now is due to be extended into their first 10 years. GP retainer scheme, this is at the other end of the person's career, and looking at how we can, as we talked about earlier, rather than people move into locum roles so that they can have that face-to-face contact rather than that wider managerial responsibility, looking at how we can create opportunities for them in terms of the retainer scheme. And then more broadly, and linking back to the work that we've just referenced in terms of working as part of the integrated care system, looking to create opportunities for GPs to develop areas of particular interest where they can work with colleagues in secondary care. So a particular area of focus at the moment is mental health, and how do we develop mental health service provision in the communities and giving GPs an opportunity in that particular area. But there are other areas such as diabetes, cardiovascular services, cancer, where we're looking to create the opportunity for GPs to become not specialists per se, but experts that then can provide extended support in their primary care networks that will not only improve the service offer for patients, but actually will be very attractive in terms of recruitment and retention. And that builds on a legacy of work that we've done previously in terms of international recruitment and working particularly with the university, to extend the training opportunities for GPs locally.
Okay, thank you. Now I've got a number of speakers, so I've got Councillor Cleaver first, and if I can just reiterate, because we are quite behind on time, just keep them succinct and concise. Councillor Cleaver.
Thank you, Chairman. And obviously, I've not got a lot to add to the questions I put previously. I just wanted to know, just to follow up really on the public understanding issue.
Can you come back in a few minutes? Thank you.
Sorry?
Sorry, somebody just came in. Sorry, I missed that.
Just to follow up really on the better public understanding issue. I noticed, for example, that the ICB has an excellent YouTube channel. It's got excellent content. It's got some superb videos. It only has 9 subscribers. And there's an excellent video on there about getting an appointment with a GP practice, about all the different roles, additional roles of who you might be signposted to see that. That excellent video has only had 85 views. So, I mean, just to reinforce the fact that I do think you have a lot of work to do in terms of better public understanding, not just of the technology, but of course, very importantly, what people who don't have access to technology need to do. I've come across issues, I just really want to highlight these. My GP practice sends web links to phones that aren't smartphones, which is incredibly frustrating to people who have a phone that isn't a smartphone and can't use the link. I really think that something needs to be done about that. Also, NHS app is brilliant, very, very good. Anyone I know that's used it loves using it. However, not all GPs actually allow the messaging service on it to be switched on. Very frustrating. You go to the GP app, I can reorder my meds, I can't message my GP. I have to go to the online portal, Doctrine portal, and answer a whole load of questions that I've answered lots of times before just to put a message in. And finally, again, just to reiterate, enhanced hours. Please, could you ask every GP in Lincolnshire to put on their website exactly what they're doing with enhanced hours so people know? Because again, it contradicts the comms, or it appears to contradict the comms that the ICB puts out directly on Facebook and Twitter, for example. So those really were just some points I wanted to add, because obviously it's pertinent to your report and not specifically to the LCM one. Thank you.
Thank you, and I won't repeat the discussion we had previously, but really value that feedback and would absolutely concur. There's much more we need to do in terms of communication with the public to help them understand the services, and we will be making sure that the information around extended access is on all of the GP practice websites.
If I could just add to that, Sarah Jane, if I may, there is going to be some national and regional resources for the public around how to access primary care services and what all the different roles within the GP practice do. So I think that gives us an opportunity to really reinforce the local messages, but really helpful to get that feedback. Thank you.
Thank you. I've got Councillor Allen next.
Thank you, Chairman. I'm not totally sure the question is going to be greatly different to what we said in the first paper. So I'm really just going to make some comments that might feed into our colleagues in the NHS and the in general practice in terms of addressing some of the issues that we've raised. The paper talks about 4.3 million contacts. And I have no idea what contacts means in the, it's a different report, so it talks about contacts. The other report talked about appointments. We ought to have some degree of consistency so we understand what it is that they're talking about. I have a feeling there's probably not a great deal of difference between contacts and appointments, although what an appointment is still a bit unclear in my view. I would like to try and find out more information about the pressures on general practitioners, be they partners, locums or salaried staff, because it is clear, I think, that a lot of pressure that's probably being brought to bear to GPs in their various forms is associated with all the side work that takes place, and to the detriment of frontline patient contact. And I do feel that probably everybody is very, very busy, doing all sorts of things within the NHS side of general practice, or general practice as a whole, but not necessarily seeing the patients. And to a certain extent, this paper illustrates that. You know, there's all sorts of things that doctors can do to further careers or to create greater interest in terms of their training, etc., etc., and which must take them away from frontline patient care. And certainly, I think we've seen in previous reports of this sort of nature, there are an awful lot of additional people working in general practice in terms of the support staff. I remember a paper that said it's been, might not have spent all the money that's been available for this purpose, but there's certainly been quite a lot of success in appointing people, and that the number of people that we've got working in the support side of general practice is way above the average across England as a whole in Lincolnshire, which may well explain then why we can have appointments up without necessary face-to-face contacts with GPs going up. So I would like to see some information that shows what degree of doctoring takes place within the GP profession in terms of seeing customers. That's what our patients, that's what our ratepayers and voters and taxpayers want to see. They want to see doctors, and I'd like to see some information that says, are they able to see doctors any more frequently now than they could in the past? There were problems before COVID started in terms of gaining access for appointments, so it's not very helpful in terms of going back to that particular problem. Certainly it's been very, very difficult during COVID to actually see a doctor. And I'm not totally sure it's a great deal easier now than it was. It's certainly a bit easier than it was during COVID, but I'm not totally sure it's much better than it was in 2019. And the good old days of being able to see doctors quite frequently, I think, you know, in the 2010s or whenever it was, when my father practiced many, many years ago, where you just turned up to the surgery and you eventually got seen on the day, have been and gone. We really need more information, Chairman, to understand what it is that's happening. There seems to be an awful lot of doctors around. There's growing numbers of doctors, but from what I see, the doctors do less doctoring. And I think we need to understand that so that we can understand what the solution is to the issues that our communities are suffering, because it is quite clear it is very, very difficult to get to see a doctor, particularly if you feel it's important that you do so.
Thank you, and I think we'll pick up on some of those points when we have the paper back to us in 6 months' time anyway, so yeah. I think that's certainly noted down. Got Councillor Smith next, please.
Thank you, Chairman. Going back to locums, because Sarah Jane's raised this, if they do less paperwork, so that's why some doctors wish to become locums, surely a solution is that normal GPs have less paperwork and actually see patients more than sit and do paperwork. So you actually have less locums, which means it costs the NHS less money, which then means they have more money to invest in standard GPs or salaried GPs or partners or whatever. And this is only going to exacerbate the wider issues. And of course, Sarah Jane talked about other specialisations that GPs could undertake or around and become experts in. Well, to me, that is a concern, to say the least, because actually GPs are struggling to do what they already have. You don't run before you can walk, and at the minute we're struggling to walk. So why would you then say, oh, you're going to go and run a mile and give them more to do? Because that will be more things that when you try and see, I don't know, a surgeon, or you try and see a specialist, we all know, go and see the GP, and it's, well, I've been waiting for 6 months. That, to me, that's given me huge alarm bells, Chairman, because actually it will be, oh no, you can't go and see the specialist who you used to go and see for this. It will be go and see the GP and wait 6 months. Well, in 6 months, I don't know what, you know, depending on what your ailment is, anything could happen to you in that time, you know. As you'll know, Chairman, I used myself as an example. Like during COVID, I waited 6 months when I had stomach issue, ended up in A&E, thankfully nothing wrong. Could have been a very different story, because quite simply during COVID, for love nor money, you couldn't see a doctor or a GP unless it was COVID related. If it wasn't COVID related, people didn't want to know. It was quite simple. So the fact that you're looking for them to specialise in more areas of clinical care when we're struggling already, to me, is a huge mistake. Yes, it might be a recruitment tool, but from a user's point of view, that's a huge concern, and I'd say a huge mistake to do, because we can't see GPs for what we need to see them for now. So you don't add to that you don't add to a burden that you can't fulfil at the minute.
Thank you, Councillor Smith, and I think you have perfectly illustrated the sort of like the complexity of the challenge that we face in terms of we need to provide excellent access to primary care and general practice services. That will be enabled by us having a strong workforce. Recruitment and retention is a key tool, and making posts attractive to encourage that recruitment, and creating opportunities that give people the incentive to stay working in Lincolnshire. And it is a very, very complicated and fine balance in terms of meeting all of those things. And if we don't get them finely balanced, we will find that any one of those things it deteriorates. So if we don't create the opportunities in terms of recruitment and retention, we won't have the workforce, therefore we won't be able to meet the needs. I think Reid may join us and just come back in terms of the specialists and some of the specifics around that. But I think you have perfectly illustrated just why this is so complicated and why we need to be very, very dynamic in our approach, because ultimately we are all very, very committed to delivering the best for the patients of Lincolnshire.
Yeah, thanks, Sarah Jane. Apologies for coming back in. I just thought it may be useful to put additional context on the queries, which I think are exactly, as Sarah Jane says, a great reflection of the fine balance that we've got. So having GPs who specialise in other things, be it they're an expert in dermatology, it helps with recruitment and retention in an area that's challenged like Lincolnshire to get people to come across to see us from more densely populated areas. But also it's a reflection of the direction of travel in the healthcare system in general. So we know our colleagues in secondary care are also don't have enough staff, and there's a move to put care closer to home for patients so they can access it in their community, particularly in areas challenged with infrastructure like Lincolnshire. So we need that workforce in the community, which is largely GP driven. So that is a great example of how these services I was talking about earlier are interlinked intrinsically to provide that service. So as models change over time, we might see there are more GPs specialising instead of the things we've traditionally specialised in terms of dermatology or vasectomy or joint injections, things like that, minor surgery. We might see more who specialise in gynecology or neurology, and they may sit in clinics in the community, so patients don't have the same transport issues and infrastructure issues, and that will relieve pressure on secondary care, who are also struggling with backlogs, as we talked about, and workforce. But yes, we would have a net effect on the GPs available on the front line to do normal GP work, unless we can get more GPs into the county. But that's a perfect example, thank you for raising, of the interlinking between all those elements.
Okay, thank you. Once again, I'll just remind people that we are very, very low on time. We've gone well over. So I've got Councillor Chalmers next, and then I've got Councillor Parkin and Loughagan, and I'm closing down the debate.
Thank you. Mine's a little different. I'm going to talk about recruitment, and about 5 months ago, the recruitment team for Lincolnshire Health was here in this room, for want of a better word. From there, they contacted me, and I went over to Lincoln for a morning, had a big meeting, and they are going to come to Boston as a trial, learn the joys of Boston, because we are more than just Boston Stump, and what it would take to, or rather what our appeal is to attract people to Boston and its surrounding areas, and use it as a trial run in recruitment to get doctors to move specifically to that location, because one of the biggest problems we have here, and it's just been referenced again, is that we're recruiting for Lincolnshire, which is wildly different and appeals to lots of different people. If this is a success, their plan is then to roll out that concept idea of recruiting for Boston and for Grantham and for Skegness and for Horncastle and for Louth and for Lincoln, because they're all unique places with individual things to offer any potential employee, whether they're GP or hospital. And I think it's brilliant. I'm really looking forward to seeing the results. Their next meeting is in December, and next time we talk about recruitment, I'll give you an update.
Thank you, that's good and helpful. Thank you very much. Councillor Parkin.
Yeah, just made some notes as I've been listening to the debate. And I think we've got to be really careful in here that we don't see professional development as a dirty word, because it isn't. And, you know, it is... I recognise the concerns in terms of do people then lose control of the chalk, you know, contact with the chalk face. I get that. But if we do not offer clear career pathways within any profession, whether it be medicine or anything else, we are not going to hit any of the recruitment problems and issues that we have in Lincolnshire. And it's not just medicine, we know that it's teaching, it's social work, it's everywhere. And so, you know, bit of a sense check, I think, to us there. Obviously then, what we are talking about fundamentally in this meeting today on both papers is the interaction of patients at the chalk face, their access, which I agree is a real challenge. But one of the things that we've not discussed, we've talked about GPs as if they're their only player in town. My family have had superb care from nurse practitioners. My children, and I've got, you know, 14, well, early 20s and teenagers, they would prefer by a million miles, and it's not because the GPs are rubbish, far from it, but they choose to have an initial conversation with the nurse practitioners and all the rest of it. So we've got to be really careful that we don't just become fixated on that one thing, and that we're open and we're adaptive to see the strengths of the models as they come through, because fundamentally what we're talking about is patient access to the best person for their need at the right time. Now, we've not got that right in Lincolnshire, but that does not mean we carry on talking about them seeing a GP on the same day, because people may not actually need to do that, and a GP may not actually be the best person for them anyway. So I feel that the debate has been really good and it's been really useful, but I just feel that we're potentially talking about one thing, GPs, when in fact we're missing the whole big picture.
Thank you, Councillor Parkin. I think that's really helpful, and I would absolutely agree. This is about a wider service and a team of highly trained professionals.
Yeah, thank you, Sarah Jane, and thank you, Councillor Parkin. I think the problem is, from the point of view of the committee, that the thing we get in the neck the most is access to the GP, and that is the thing. So, absolutely. Okay, I've got, finally, Councillor Loughagan, please.
Thank you, Chair. Just a comment, really. I spent 36 years working for the public service, and by the end of it, I was a qualified practitioner as a probation officer, and by the end of it, probation officers were spending 85% of their time inputting data onto software, and were criticised highly for spending too much time in face-to-face work, which was where our expertise and skills lied. The establishment of the ICP offers an opportunity to take a step back and just check on what we're prioritising. I have huge sympathy with anyone in public service. You have to spend so much time justifying your existence with all the threats that come from privatisation. But at the same time, we need to actually step back and look at what we want our practitioners, whether they're general practitioners or nurse practitioners, to be spending their time doing. Thank you.
Thank you, and I would absolutely agree, and I think that is a particular focus of colleagues in the ICB to make sure that we best utilise the skills to meet the needs and support patients locally.
Thank you. I'm going to close the debate now. I've just got two final questions. I think one's particularly quick to answer anyway, and the other one shouldn't be too bad. And that is, do you know how many of the CQC ratings of GP practices in Lincolnshire found on page 46 of the report are based on inspections over 2 years ago now?
I can't answer that question specifically, Carl. I'd have to go back and have a look at each one. I know that there are two specific that are outstanding, which I've referenced in the report, but I can provide you with that information.
That's absolutely fine, thank you. And there is a lot of experimental data on the NHS digital website which enables comparisons with other ICB areas. For example, in Lincolnshire, the number of appointments in primary conducted by a clinician other than a GP is the highest of all ICB areas. What is the ideal ratio of appointments by a GP compared to appointments with another clinician?
Again, I think that's quite a complicated area of discussion, and I wouldn't be able to give you a specific, but I'm happy to come back and have that conversation with clinical colleagues supporting that debate. I think it varies depending on the patient need, which is why I think it's much more complicated. But I'm happy to come back, Carl, and have that conversation.
If you could, please, that'd be great. Thank you, Sarah Jane. In which case, I'm going to move to the proposal that we thank NHS Lincolnshire's Integrated Care Board for its report and presentation on GP provision in Lincolnshire, that we note the developments in primary care, such as the increase in clinical pharmacists, first contact physiotherapists and occupational therapists, but seek assurance the ratio of appointments conducted by GPs as opposed to other clinicians in primary care is meeting the needs of the Lincolnshire patient. In addition to seeking a further update in 6 months' time to seek a more detailed report on the role of primary care networks in advance of this, and also picking up on Councillor Cleaver's point, I think we could do with the more information and more pushing from our NHS colleagues for promoting enhanced hours on GP websites, not sending web links to non-smartphones, promoting the YouTube channel better, and encourage more use of the messaging apps. So I'd like to pick up on those as well, please. That's my proposal. Do I have a seconder, please? Councillor Linda Wootton, thank you. All those in favour, please show. Thank you very much. And just finally, thank you, Sarah Jane. I think you're either away or for whatever reason you couldn't be here in person today, but thank you for attending. And also
thank you, and I will leave you in my colleagues' hands because I am, as you say, away. So
thank you, Sarah Jane.
Thank you all this morning. Bye-bye.
Thank you very much. In which case, we'll now move on to agenda item 9, Hawthorne Medical Practice Skegness CQC report. This item was circulated as part of the agenda pack, pages 59 to 96, and I'd like to welcome our presenters from NHS Lincolnshire's Integrated Board via Teams. We have Wendy Martin, Associate Director of Nursing, Terry Vine, Deputy Director of Nursing and Quality, Linda Stockwell, Deputy Director of Nursing and Quality, and Sarah Starbuck, Head of Transformation and Delivery. So if we could take the paper as read, please, and just have a quick sort of run through and questions at the end. Thank you.
Thank you, Chair. So I'll just start and give a very quick summary of the paper. So as outlined, Hawthorne is based in Skegness and it has a branch site in Borough La Marsh. The list size is 17,777 and the provider is a partnership of 8 GPs with just under 7 full-time post equivalent. The Care Quality Commission visited the practice on the 23rd of August as part of their routine regulatory activity, and the practice was rated inadequate overall, with an adequate in the safety domain, responsiveness and well-led domains, and requires improvement in effectiveness and caring. Because of this overall rating, the CQC have placed the practice in special measures. The report and evidence are published on the CQC website, and I've also provided them as appendices to this report. The key findings from the CQC was that the practice did not always provide care in a way that kept patients safe and protected them from avoidable harm. There was no effective oversight of dispensary services that provided assurance as to safety at the Borough La Marsh site. Patients did not always receive effective care and treatment that met their needs, and the practice had not taken reasonable steps to protect patients and others from the risk posed by healthcare associated infections. Staff dealt with patients with kindness and respect and involved them in decisions about their care, but patients could not access care and treatment in a timely way. The provider did not have effective oversight of the systems and processes designed to deliver safe and effective care. Governance systems were ineffective, and staff did not always have the training, supervision or appraisals required. In terms of what the ICB are doing to support the practice, there are fortnightly meetings with the partners and the senior management team of the practice from the ICB primary care team and the quality teams. This is to discuss progress that's been made in addressing the issues identified by the CQC and to provide support and guidance and signposts to resources that are available to the practice. In between these meetings, the primary care and quality teams are based at the practice at least once a fortnight to offer additional support and guidance, and obviously available remotely in between times as well. Support has been offered and taken up by the practice includes the ICB chief pharmacist and the Lincolnshire integrated management team, medicines management team, support with the dispensary issues identified and the other prescribing issues. Visits to neighbouring practices for learning and identifying how they address some of the issues from that the CQC identified. This included Spilsby practice, where the ICB clinical lead who's been supporting us with the practice, Dr. Howarth, is one of the partners. The infection prevention control advice and visits came from the ICB health protection team, and then we actually requested that they brought their routine visit forward that was planned for later in the year to help the practice with the issues that were identified and some of the resolution around that. And we've also had, the practice also had support from the local medical committee and particularly from their practice support team. They're also accessing the Accelerate programme, which is an NHS England programme support practices in relation to patient access and picks up some of that patient flow issues that we've been talking about in some of the other papers that have been presented earlier. There's an update as well, which has come since the report was written, but the practice now has a strong and robust action plan in place with clear timescales and ownership for each of the actions. This has been developed in conjunction with the ICB and following the practice discussions with the CQC last week will be shared with them today for their information and their comment. In terms of reporting and oversight, the ICB has regular structured agenda and minuted meetings with the practice fortnightly, which also have an action log and progress is reported against these agreed actions. Progress is reported formally into the locality primary care quality assurance and operational meetings through to the primary care quality and performance oversight group, and then into our primary care commissioning committee, which is there to provide assurance to the integrated care board. CQC will inspect again 6 months following publication of reports. That's anticipated at the end of March. However, the CQC will also expect regular updates from the practice against their action plan. Also, as an ICB, we have regular meetings with the CQC about all of our practices, so we will have regular conversations with the CQC about the progress. So just asking the committee to note that the Hawthorne CQC report has been published with an overall rating of inadequate, which places them in CQC special measures. We also ask you to note the support being provided by the ICP and the availability of support from other stakeholders, and we can provide further progress reports to the committee as requested. So thank you.
Okay, thank you very much. We'll start with questions. I'll start with Councillor Allen first, please.
Thank you, Chairman. Fairly dismal reading in the report, I would say, and a number of things come from it. One of which is no matter what the CQ, well, particularly in the cases where the CQC has given such poor reporting and ratings, you know, inadequate overall, and not doing the basic things like providing safe services to the community and to the patients. It seems to be so difficult to actually get changes to be made, because the final sanction, I suppose, if there is a final sanction that can actually be used, of effectively deregistering the practice and telling the doctors to go away and do something else, isn't really an option, I don't suppose, because there has to be some sort of medical provision in the area, and it can only really be provided by this particular practice, I would have thought, because as we just had lots of discussion about, we can't simply import 8 doctors, 8 GPs from somewhere else in the county to take over and provide a better service. So it does seem to be quite difficult to actually deal with these sort of difficult issues. And it's something that perhaps needs to be considered if we are actually going to have sanctions in these circumstances that are meaningful. The other thing I think that was fairly evident from the report is it must be a very difficult situation to provide a general practice provision in an area where the patients on the list increase from 17,000 under normal circumstances to over 34,000, for 3 months of the year or whatever it is. It does strike me that, the actual way that these sort of practices on the East Coast operate need to be developed in a way that allows for this, safe healthcare to be actually provided in those sort of circumstances, because otherwise, there's going to be 3 months when there must be absolutely turmoil within the practice, and I can't see how you can actually cope.
Thank you. Before you respond, I'd just like to build upon that as well, from what Councillor Allen said. I mean, after I read the CQC's report, I'm entirely shocked that a surgery that has been described as lacking cleanliness, lacking fire risk assessments, lacking up-to-date health and safety risks, lacking training on infection prevention and control, lacking PAT testing, lacking medicine management, lacking fully trained staff, lacking leadership, and lacking governance has been allowed to continue operating. Do you feel this is in any way a safe service and is acceptable for patients?
Sorry, Terry, you go first and then I'll pick up.
I mean, I think you're absolutely right. It is quite a damning report, and it is something that we're not, we don't like to read. And I think the response from the practice is to put some immediate measures in place to try to address those issues with the support from various colleagues, some of which are present here, and also other stakeholders as well. But yeah, it is something that the practice do have to step up and take responsibility for resolving. Absolutely.
And if I could just come in on the other points that was raised. So obviously the ultimate sanction is deregistration by the CQC, and you'll be aware through this committee that that has happened previously on some occasions where we have to find alternative providers for our GP provision in particular areas. Obviously we want to avoid that, both for obviously for the patients in that area, also for the staff involved. So we will work closely, as has been described, in terms of ensuring that those actions that are required are progressed. Just in relation to the surge of input in terms of patients requiring care on the East Coast, unfortunately, the picture for this year is that surge is ever present rather than being a seasonal surge. So there's that continued pressure in terms of patients attending the surgery. The practice do receive additional funding to compensate, but there is a pressure still in terms of workforce, and achieving the appropriate workforce has been discussed in previous conversation this morning.
Can I just also add to that, Wendy? In terms of temporary registrations, where we see a larger number of those who live on caravan sites along the east coast of Lincolnshire, it has improved to some extent in terms of the burden on local practices due to, as we touched on previously, some of the digital arrangements that are in place, because that can be sometimes if a patient doesn't need to be seen face to face, they can contact their normal registered GP practice remotely, and also complemented by electronic prescribing that can help in terms of prescriptions being sent to whichever pharmacy they happen to be at. But it's not discounting that is an additional burden in terms of the pressure on practices. And I'd also like to note the additional pressure that's put on in terms of the bridging accommodation that's been put in for those seeking asylum that has had a pressure on Skegness practices. So that's part of the additional areas of support that the ICB have been putting in place to support practices, both practices in Skegness in recent months.
Okay, thank you. Before I bring in Councillor Chalmers, I will state that I am actually a patient of this practice. I was there in the summer season at 9 o'clock in the morning and I was the only person in the building. Councillor Chalmers.
I think this is kind of desperately sad. And the thing that jumped out first to me was staff dealt with patients with kindness and respect and involved them in the decisions about their care. So when they're being seen, everybody loves them. They're being cared for, which is ultimately what the NHS is all about. Everything else screams to me of a massive failure in recruitment staff. If you just, I mean, you just look at this, staff do not always have the training, supervision or appraisal. Well, all of those take time, which means extra people are needed to give that time to enable these facilities. I don't know, but I'm looking at this and thinking that this is basically the result of a recruitment failure. Up to a 500% increase during the summer population is phenomenal. It's just massive. It's ridiculous. We really need to help this surgery rather than kick them. And it also made me wonder how many others are slipping towards this kind of result and paper that's been brought to scrutiny. I wonder how many others that are just 2 ticks away from sitting here as well, because we haven't got other bits to support the surgeries. That was my thought. It certainly is not a kick on the staff. That one statement, deal with patients with kindness and respect, I think that speaks volumes about who they are as a surgery and who they're trying to be.
Thank you. We do closely monitor all our practices, and indeed this practice, before the CQC visit, we had done a sort of ICB inspection and I'd put in an action plan with the practice already in terms of making improvements. So through our sort of quality monitoring processes, we do keep oversight of all our practices, and ones that are showing particular strain and needing support, we will go in there and support as much as we can, recognising that these are sort of independent practices with their own responsibilities around recruitment and obviously other areas of management, etc. But we do go in and support our practices where we are aware of a problem, both from our perspective as an ICB, but also our partners, where we identify issues that need support. This practice was particularly having support around access issues, because that was being identified quite commonly for Hawthorne in terms of issues of concern. And within their action plan now, there is the whole piece around that access and improving that access, but also around improving recruitment to vacant posts and extending the practice team. Thank you.
It was very good to read the fact that they've gone straight in with an improvement plan. But again, access, we're talking rural areas, poor phone signal, poor internet signal, and the need and that ability to walk into make an appointment or to pick up the phone, make an appointment, rather than being pushed through other systems. But thank you.
Yeah, no, thank you. They are making improvements in terms of access, in terms of improving the rota to man the telephone calls, and also making sure that there's a callback system in place as well. I don't know if Terry or Sarah wanted to add anything in terms of the access issues.
I was just going to come in about the recruitment. So some of the discussions that we've had around the practice, especially around admin staff and reception staff, some of the challenges that they've had recruiting those have been quite stark. And they put adverts out, they have people apply that then don't turn up for interview, and they've even appointed people that have then not turned up for their first day at work. So it's not just about getting the right people to even apply for the post, but sometimes even when they do appoint, those people then don't turn up. And you can definitely tell from speaking to the practice team how frustrated they are to have to keep going through that process all of the time. It must be really difficult for them.
Okay, I've got Councillor Thompson next.
Thank you, Chairman. NHS England require that the net earnings of doctors engaged in practice is publicised. There is a disclaimer on this because it is potentially misleading because it takes no account of how much time the doctors spend working in the practice, and that comparisons between practices are not particularly valid. I just found it particularly interesting, though, that the Hawthorne practice, the net earnings per GP, which I assume is net of practice expenses and costs, but before tax, is substantially greater than many of the other practices by almost a factor of 50%. I won't quote the details, they are publicly available, but I wonder whether the investment of some of the extra money into the practice might not be a bad thing, and whether the ICB or LMC could actually look at that. Thank you.
Thank you. I'm not sure we're in a position to answer that, to respond to that today. But, you know, I would just caveat with the fact that quite a lot of GP partners do reinvest their earnings into supporting the practices. So it is very difficult to ascertain in terms of how much is take-home earnings without doing some further in-depth analysis for that practice.
Okay, thank you. I've got Councillor Smith.
Thank you, Chairman. I've read some CQC reports in my time, and this is shocking. There is no other word for it. There are, as you've alluded to, Chairman, there are basic things that do not take the brains of Britain and much time to do that actually need to be done. I'm not a patient, so I don't know the ins and outs as you will, Chairman, but I am absolutely staggered, and I have serious concerns on how safe this is for patients, which hasn't been answered. I have grave concerns. What the plan doesn't tell, it tells you what the problem is. What it doesn't tell you is what are they going to do about it, how long is it going to take, and what's going to happen in the interim for patients. Because as I was reading that, I was having visions of various possible situations in my head of horror stories that could befall patients if things aren't changed quite rapidly and quick and at a substantial level, because the state of that surgery, just quite simply, Chairman, is unacceptable in this day and age.
Could I just respond on that in terms of the oversight we have in terms of the safety and quality of services? It is robust. We are working closely with CQC, who notified us as soon as they'd undertaken the inspection in terms of their concerns, so that immediate and significant risks were rectified swiftly. So the improvement plan in which the practice are working closely with us, are sharing with us on an almost daily basis, and also sharing with CQC as an interim. They're not required to. They are sharing their improvement plan with CQC this week as a kind of midway point before any follow-up by CQC in December. So immediate risks have been reviewed, identified swiftly, but there is further work to do. I'm not discounting that at all, and we're working closely with the practice in terms of that improvement plan. CQC did review this with the ICB at the point of the inspection. CQC were comfortable that they had to take no further action due to the response of both the ICB and the practice at the time, but we are continuing to closely monitor the improvement plan and delivery of that.
Thank you. I'm just going to build on to what Councillor Smith said. I mean, if you look at page 54 and you look at the bullet points there, it doesn't actually look like the partners or staff seem to be taking it seriously. You ended up with 4 members of the partners in attendance, 4 that weren't. One of those that was supposed to be making or touching base were trying to move the action plan forward, and they didn't attend, and the other partners thought they had. Have you confidence in the management there?
We've met with all partners. We meet regularly, but obviously we need to maintain services for patients at the same time, so we meet regularly with the partners. Those that are able to join the meetings do, those that don't, information's cascaded remotely, and we do have separate conversations with those that aren't physically at the regular partners meetings. There are assigned clinical leads for all areas of the improvement plan. Those partners are taking ownership of key areas, so they've got that assigned between the partnership, and we have That's structured within the improvement plan that will be shared with CQC today, which confirms that and confirms the leadership and the clinical oversight within the practice.
Thank you. I've got Liz Ball now.
Sorry, I wonder if you can tell me, Terry, from the action plan, I noted that the patient participation group is not in existence. So kind of what are you doing about that to get that patient feedback? And then secondly, on that matter, if there's anything from a Health Watch point of view we can help in supporting if you've not already made those links with us. Thank you.
Thanks, Liz. Yeah, nice to see you, Liz. Yeah, absolutely. It's certainly something that we're working with some of your previous colleagues that you know, such as Claire Hornsby and Nikki Pepper, looking. We're doing some county-wide work actually around PPG groups, because a lot of PPGs were stood down during the pandemic. So looking at how we can support practices to stand them back up again. And I was at a practice yesterday where we had exactly that discussion. So that will definitely be a feature of it, but also you're absolutely right. It is crucial for us to get out and listen to the voice of the patient. I certainly know it's something the CQC didn't talk about within the report, but we'll be using our own internal engagement team. But absolutely, any help that Health Watch can give us with that would be hugely appreciated. Thanks, Liz.
Okay, so we'll probably take something offline with Health Watch, and I'll speak to my colleagues then. Thank you.
Thank you.
Thank you. I've no further speakers as it stands at the moment. I do have a number of questions myself. Firstly, as a patient at this surgery, I've yet to see any improvements whatsoever. Only last week I rang the surgery at 8 AM to be caller 40 in the queue. I selected the ringback option but did not receive a call. I called again the following day and was again caller 40. By the time I got through, all appointments had gone. So although I was asked by letter to make an appointment, I was refused by a very rude member of staff who told me to ring back at 8 AM the following day because you can't book appointments in advance. So can you expand on what improvements that the ICB have actually seen?
So, I mean, from my point of view, I mean, that's just not good enough, Councillor Macy, and I'm really sorry that you've had that experience with the practice. I know that the practice are doing a lot with their phone access and looking at the issues that they have around their phone, the phone data. So so the phone system that they have can produce a lot of data about missed calls, about call waiting, things like that. They've not utilised that previously in the way that to its full functionality. So they're doing some work looking at that and having some really some targeted work at looking at access. As I said, they're also accessing the Accelerate programme as well, which looks at a lot of that patient flow stuff and helping the practice with the patient flow. And also going out, part of the reason why they've been going out to look at other practices is to look and see what other practices do. So absolutely, it's not where what the practice themselves want to be, and it's certainly not where the ICB want them to be. So access, yes, is absolutely still a challenge at that practice, and we'll continue to try and support them with that.
Thank you. Another one of my questions. The CQC report states that Hawthorne operates from sites in Skegness and Borough La Marsh, but no mention is made to the surgery it was operating in Wainfleet. I do believe this closed due to staffing issues over COVID and has never reopened. Does this mean the Wainfleet surgery is now deregistered? And if so, why hasn't this been consulted on?
Okay, I can pick that one up. So Wainfleet Surgery, as a smaller satellite service that was running prior to COVID, isn't no longer in place. If we were ever to remove any services, we would of course consult with patients. So it was a satellite service at Wainfleet that ran for one morning and one afternoon per week, and that followed patient consultation following the closure of Wainfleet Surgery some years ago. As patients continue to be registered at Hawthorne, have the choice of the two sites, but it was used as a hot site, so for COVID positive patients throughout the pandemic. The focus at the moment, as you can see from some of the issues that have been raised, is we've been focusing on access for the main site and the branch surgery. at Burrell Marsh, but no, there is no change. But at the moment, the outreach service at the moment hasn't been put back in place, and some of that is due to staffing, because obviously it's an additional site which would need to be manned by reception staff and additional clinical staff. So at the moment, as I'm sure you can appreciate, we're focusing on getting the required standards for services at the core site and the main branch, but we have not decommissioned services from the satellite site at Wainfleet, and we would hope to have that in place again as soon as possible.
Okay, thank you. I think it was partially alluded to by Wendy, but as the ICB and CCG as it was, has had oversight of all of the Lincolnshire GP practices, and as you've already said that you were aware of some issues at Hawthorne, how is it that you've allowed it to get to this truly damning point? Because whether or not it's a private practice, it is funded by taxpayers' money.
So, I mean, as I said, I mean, obviously during COVID, we did have less capacity in terms of quality assurance of our GP practices, but nevertheless, we maintained our quality assurance processes. There were some concerns with Hawthorne that we were continuing to follow up, but I think the extent of the findings through the CQC report took both us and the CQC to by surprise in terms of the extensiveness of the serious concerns, and we're obviously as concerned as you are in terms of making sure that they are put right quickly and addressed quickly.
Okay, thank you. I've got Colin Matthews, I believe, that would like to come through.
Yes, thank you very much, Chair, and thank you very much for all those attending and addressing this matter. I have raised previously some concerns about a neighbouring GP practice to this in Mablethorpe, and we take all this in the round. It means the East Coast between Wainfleet and coming round the coast through Skegness.
Colin, it might be worthwhile sticking your camera off and just trying to use the audio because you're freezing and breaking up.
Sorry, I have very poor signal here. Basically, it's to say I fear this is not an isolated case on the East Coast, and I hope that action will be taken to improve service around the coast following this expose, really. Thank you, Carl.
Thank you. Can I just respond on that? Because I think we have done some significant amounts of work with both Beacon Medical Practice and Marisco Medical Practice as neighbouring practices within that PCN footprint in recent months. You will note from the CQC website that the Marisco, at the latest Marisco Medical Practice CQC inspection has now been published, which does place them as good overall, and so it does demonstrate significant improvements in terms of access and quality of care at neighbouring practices. What we are doing is continue to monitor delivery of services at both of those practices to ensure that's maintained and continuously improved, because obviously we would hope all our practices are outstanding, but we continue to work closely with those practices.
I will just respond to that to say that, like Carl, who is a patient at the Skegness, I'm a patient at the Marisco practice, and I'm not seeing those improvements in evidence or seeing them from the feedback to me from my residents who are contacting me about the poor practice. So I'm pleased they're good. I'm pleased you're working with them, but actually on the ground, that is not being seen as good practice in the way they respond to patients.
Okay.
I know I haven't got the evidence that you have. I'm just telling you what is the situation on the ground.
Okay, and I think that feeds into what we've previously said about we need to hear the patient voice, because we need to understand where it's not feeling as if services are improving or there are still difficulties for patients. So that does involve working closely with colleagues such as Healthwatch to get any relevant feedback from yourselves if there's anything that's shareable with us as commissioners to review. So we've got the insight into concerns that are raised, but also we do proactively go out and speak to patients. We run listening clinics quite often on practice sites to try and hear that patient voice. But if you feel that's not being captured, we're more than happy to review other options of how that can be done, because obviously that's key to us to understand what the patient view is so we can respond to it and support those improvements.
Okay, thank you. I've got Councillor Cleaver.
I'd just like to make the observation that many people find it surprising that when a publicly funded, contracted out service is deemed to be inadequate, woefully inadequate in this case, that isn't automatically deemed to be a breach of contract. And frankly, I find it surprising that the ICB doesn't, as a reflex action, immediately serve notice of termination of that contract, with that notice only being rescinded when the practice concerned is taken out of special measures and again is rated as not inadequate.
I'm happy to respond on a contractual basis. So in terms of notice for contract, we do take any contractual action seriously, and in terms of any breach notices that may be applicable for any practices that are in breach of their general medical services contract. If we were to serve notice, it would be to serve notice. We cannot do one that would be pending further outcomes. So what we do is we work closely with the practices to support them, because we want to improve and maintain services, but that does not mean we do not take contractual action if it's required, and then also work closely with CQC as the regulator. So I do hear what you're saying. I do understand the concerns, but we also have to work within the national framework of the regulations we have to work within.
Yes, I hear what you say. I simply think that it's the public understanding of this is difficult, because in any other sphere of activity which is publicly funded, a breach of contract, providing an adequate service is de facto a breach of contract, and I just think that that needs to be something that we should be reviewing, frankly, as a scrutiny.
Councillor Smith, you'd like to come in just with a short question?
Yes, thank you, Chairman. It goes back to what was said around the regulatory framework around COVID. And I'll be blunt, Chairman, residents, and I'll be honest myself, I'm getting quite thin in terms of patience around using COVID as a justification for things slipping, i.e. quality of service or regulatory framework saying, oh, we haven't been able to do X, Y and Z. Well, nothing. The shops didn't stop, the hospitals didn't stop, I certainly didn't when I had a role with vulnerable individuals because they couldn't get access to any form of data. Residents' patience on this front is getting quite thin now. I appreciate it's still about, I appreciate we still have to have, common sense and be careful. I'm not saying we don't, but using it as a partial justification, it's getting very old, very thin, very quickly. And it's not just me that feels like that. There are a number of residents, because they'll have the same thing. Oh, well, you can't see the GP, you can't do this, or it's taking this long because of this. Okay, this has happened. Money has been, if it hasn't been, money needs to be given to you to correct this. But to keep using it and keep coming back, it's getting very thin in the wedge, Chairman, and the very thin end.
Just in terms of that, just sorry if I gave the impression that we'd stopped anything during COVID. Obviously, quite a few ICB's previous CCG staff were redeployed during COVID in terms of the vaccination programme. So we had less staff in terms of quality assurance of our practices, but the processes for quality assurance were maintained with the staff that we had. If that was the impression that I give, then I apologise.
If I may, I think, Councillor Smith, and you can correct me if I'm wrong, I think you're meaning more in terms of access to GPs in general, not specifically to this site, in terms of there has been a common belief that GPs have been in hiding since COVID.
That, Chairman, and I know it wasn't, the regulatory framework wasn't stopped. You were very clear on that. My point is, it obviously didn't function how it should have during COVID. I appreciate that there was redeployments and I appreciate why, but something obviously hasn't functioned properly in that interim, because if things had, one would hope that the surgery that is before us wouldn't have got to that stage if it had functioned as the regulatory framework intends it to function. That was my point. I appreciate it's not stopped, but something's not worked during that time. That much is apparent and obvious.
Thank you. I won't come back on that. I suppose it's just to say that yes, part of the regulatory framework was face-to-face visits, and obviously quite a few of those were suspended during COVID, both from an ICB and a CQC perspective. So CQC regulation during the COVID period was done through data analysis and virtual inspection rather than on the site inspection, which probably answers some of your concern.
It does, thank you. In which case, I've got two further questions. I'm going to close down the debate. So that is on page 86 of the pack. It refers to around 700 to 800 appointments per week in the practice, but 1,200 appointments would be expected each week when using the national calculation. Do we know where these 400 to 500 patients are going per week? Is it Skegness UTC or A&E at Pilgrim?
I would have to take that away. I don't think I can respond today on that question. I'll take that one away. I mean, I think UTCs across the board have seen more activity, and that's just not in the Skegness area. Our ED activity is actually less than pre-COVID. It's just the type of patients that are presenting to ED that are creating the bottlenecks within ED, and then the discharge issues with ED. Sorry, I don't know if I'm rambling a bit, but does that answer the question? I think the UTCs have seen more activity, but that's across the board, not just in the Skegness area.
No, but I think it'd be useful to know where the displacement of those patients has been. My final question
Could I
is...
just come in on that? Because
yes,
I don't
you
know
can,
if
yes,
that
certainly.
refers to, because there is BMA guidance, which the CQC do refer to in terms of levels of appointments they would expect to see based on the patient list size. In this case, it was lower than the CQC were expecting to see in terms of numbers of appointments, but it was immediately rectified by the GP partners. So additional appointments have been put into place. So I think it was, if I'm reading it correctly, we will review so we can respond fully, but it may be in terms of expectations around levels of appointment numbers based on national guidance, but that was immediately rectified and additional appointments have been put in place.
Okay, thank you for that. Does seem like a large swathe of 400 to 500, but I would be interested in a sort of more robust response, but thank you for that. My very final question is there anything the ICB can do to support the practice overcome its accommodation constraints, as the current accommodation is designed for a list of 9,000 patients?
I can come in on that as well. So we do have a small amount of vacant space within the practice building at the moment, which we as a commissioner approved some time ago, and that's with practice solicitors to arrange the lease arrangements, in which case we've agreed sometime well before any of the issues were identified that additional capacity would be useful for the practice, and we've been supportive of that. That's in progress. I've actually been in touch with the practice manager via email this morning to try and support them with that. So we are looking at interim additional capacity on the site, which the practice doesn't currently utilise, but that we will support and fund. What we are also doing with all primary care networks across the county at the moment is a programme of assessing their clinical strategies, which will inform their estate strategies. So there is a programme of work within Lincolnshire that is midway through at the moment and will be concluded by the end of the financial year to understand what estate is needed to make sure we can meet the longer term needs of all general practice within Lincolnshire. I'm happy to provide further updates on that at a later stage.
Thank you, I think that would be useful. Okay, in which case I'm now going to move to a proposal that we record the committee's grave concerns on the services provided to patients by the Hawthorne Medical Practice in Skegness, following the Care Quality Commission's rating of the practice as inadequate and the consequent placement of the practice in special measures. That we note the support given to Hawthorne Medical Practice by NHS Lincolnshire Integrated Care Board, and stress that responding to phone calls and increasing the number of appointments need to be addressed as a priority, and that we also seek a further report to this committee after the publication of the next CQC report, unless the NHS Lincolnshire Integrated Care Board is not satisfied in the interim with the progress made, and also that we have the action plan shared, please. Do I have a seconder for that proposal? Thank you, Councillor Smith. All those in favour, please show. Thank you, that's supported unanimously. And I would just like to thank you all for coming and presenting to us today. So thank you very much. We'll now move on to agenda item 6. So that's the ICS Clinical Care Portal. And I'd like to welcome our presenters, Samantha Francis, Information and System Manager for Adult Care and Community Wellbeing for Lincolnshire County Council, and David Smith, Digital Programme Director for the Lincolnshire Integrated Care System. This report can be found at pages 29 to 36 of the pack. And I'd just like to apologise to keep you waiting and thank you for your patience. So I'll hand over to you if you would just to run through the report quickly. We'll take it as read, but we'll take questions at the end. Thank you.
Lovely, thank you, Chairman. So yes, I'm Sam Francis, the Information Systems Manager in Adult Care and Community Wellbeing. We're bringing this report to the committee today as an update after we came to you in January. A number of questions were asked during the January committee, which have been addressed in the appendix at the end of the report. And we've given a brief update on activity for social care and health since then. My colleague Dave Smith has attended today to provide any additional responses or any answers to questions in relation to the health side of things. Let me just scroll down. And we're asking the committee to receive the report and note its content today. The background information was as it was in the previous report in terms of the intended evolution of which organisation is going to be sharing data through this system. The main update to provide from a social care point of view is that at the last meeting we advised that health data was viewable by practitioner staff in social care via the Mosaic case recording system and had been since February 2021. And the update at this meeting is that an agreed data set from Mosaic has been shared so that health practitioner staff can view that via the care portal. And that's been live since April this year. You can note as well that we have ongoing inputting from our social care hospital teams to shared care planning via the care portal with our NHS colleagues in the hospital bases. And there have been some updates in terms of the organisations with access to the care portal and the data sources that are feeding into the care portal as well. So we've got a number of NHS, social care and other parties that are feeding into those. And if you've got any more questions, I'm sure Dave will be able to pick those up. Future portal development, I think this was mentioned on the previous report in January, but the intention is that this will include patient portal and an analytics module. And as mentioned, the first appendix in the report identifies additional data from what we provided in January in terms of the weekly care portal health record views by social care practitioners who access it via the Mosaic recording system. So there's additional data in terms of our number of users accessing it, and figure 2 is the new data in terms of the weekly Mosaic social care record views by health practitioners via portal, which, as I say, has been live since April. And Appendix B is the answers to the questions that were posed last time. So that's my update.
Thank you. I've got Councillor Loughagan first, please.
Yeah, forgive me if this question was answered back in January. I wasn't on this committee then. Could you explain to me how patients and their carers were informed that this data was going to be shared, and how good people's understanding is of how and how often their data is shared between health and social care? Thank you.
At the start of the programme, there was a campaign. Sorry, thank you, Sam. There was a campaign. Our SRO at the time, Gary James. Some of you may be familiar with Gary. Was the former chief exec of Lincolnshire CCG. So he went on BBC Radio Lincolnshire to promote it. There were posters put up across all of our provider sites as well, in prominent locations, so patients were informed and you know, it was transparent with them. And we've also had a policy by any clinician that interacts with the patient during a consultation makes a point of saying. Sorry, pull the mic a bit more to you, not the great explanation, but it's sort of directly in front of you. Right. Okay. Sorry. Thank you. Excuse me. And again, there was instruction to all the clinicians that actually engage with a patient during a consultation that they are actively encouraged to ask them if they're okay to access their shared care record and they've got permission. And it's sort of an ongoing piece of work that we have basically going on at the moment. I think in addition to that, sorry, I should probably add that there's information available on the website as well that we promote and published at the time.
Thank you. Could I just come back and ask, does that happen the other way around with the Mosaic users in adult social care? Do they specifically tell people face to face that their data is being shared? Thank you.
The information that's shared, so Mosaic, are you meaning social care data being shared across to health? Yes. So in terms of that, we've got the agreement, the shared data agreement, in terms of we have a duty of care to have that holistic picture and that duty of care to those social care users. And when assessors are talking to them, again, similar to what Dave was saying, when assessors are talking to them and they're part of the care and review pathway, they have that conversation around use of Care Portal and use of those wider systems to have a holistic picture of their health and care pathway if they're known to both sides of the service.
Okay, thank you. Any further? Yeah, Councillor Cleaver.
Thank you. I think it's a great initiative, and it's lovely to have this update from you. Most grateful for it. Obviously, as we've kind of been discussing earlier on today, most of people's interactions with the healthcare system are through their general practice. So I'm interested very much in knowing the extent of uptake that there is with GP practices in terms of viewing the data and providing data to it. Have we got a full uptake? Is it being well used by them? Are they now in a mindset where if they see an alert from me that I've just gone on Doctrine or gone onto the online platform and said something, they will automatically check whether there's any incoming records that I've recently been to the minor injuries unit, or if I'm an elderly person, I've been seen by adult social care. What's the level of usage that we're seeing? And if we've got people who aren't any GP practices within Lincolnshire who aren't linked into this, what are the areas of friction? What are the reasons that are preventing them from doing so? Thank you.
I'll take that. Thank you. Difficult question to answer for a very good reason, actually. The uptake, generally speaking, it's variable, I think, is to answer your question. There's variation around primary care, and to some degree that's symptomatic of perhaps the information that we currently have in the portal, perhaps the proximity of some of the practices where they're located geographically. So a lot of the practices that are in sort of central Lincolnshire that are referring a lot of their patients to, say, United Lincolnshire Hospital, as opposed to, say, North West Anglia Foundation Trust, which would be Peterborough, or maybe North Lincs and Goole. We haven't got as much data coming in from those other external hospitals at the moment. So for that reason, those practices on the fringes of our county perhaps aren't using it necessarily quite as much. I think we recognise that, and those interfaces that we need to put in place with the likes of North Lincs and Goole, so we can capture data for patients that are referred into Grimsby, Scunthorpe and Goole accordingly, will hopefully improve that situation going forward. We have seen a significant uptake across the GPs in the south of the county following the integration work we completed about 12 months ago into Peterborough, because their initial response to some degree when we sort of went out to market the Care Portal from a primary care perspective was the fact that they already get lab results, they already get radiology results from Peterborough. What they were interested in was whether or not they could see referrals, appointments and encounters for their patients. That was the one thing that was really missing from their perspective. I'm pleased to report we've delivered that. And we've had really positive feedback from the GPs in the south. So that's sort of the setup around primary care. Within each of the providers, there is very good take-up. There's huge adoption in United Lincolnshire Hospital. I think mental health, so Lincolnshire Partnership Trust and Lincolnshire Community Health Services have only sort of integrated over the last sort of 6 to 9 months. So there's still more work to do from my perspective in terms of promoting the usage and adoption within those organisations. Hopefully, Councillor, that goes some way to answering your question.
Thank you very much. Good to hear.
Thank you. Any other questions? Yeah, Councillor Allen.
Thank you. Thank you, Chairman. I've been on this committee for about 2 years now, I'm getting on, no, 18 months. And I look continually in our various reports and papers for good news about what my interest is. And my interest is obviously the health of my residents and the residents across Lincolnshire as a whole. And, you know, something that says, and this is improving, you know, people are, you know, being affected in a very positive way in terms of getting the healthcare provision that they actually want. And I have found that there's numerous initiatives that take place on a week-by-week basis almost in terms of providing those benefits, although they seem to be difficult to actually see actually happening from a fruition point of view. Lots of things happen, but they don't seem to have a great deal of improvement. And it's very unfortunate because we do have a situation within the UK, and that includes Lincolnshire, where average life expectancies is getting poorer quite considerably. You know, something like 1.7 years for a male and about a year for a female, and that is the first time it's happened, I think, in almost recorded history. All the way up to now, life expectancy has been increasing, and it has now gone into reverse over the past 5 years or so, particularly more recently. And that is worrying from my perspective. And if it was perhaps more widely broadcast, it might be worrying to the population as a whole. There's an initiative. There is an initiative here, which hopefully is, you know, could be seen in a very positive sort of way. I'd just like to go back to the final few words in your conclusion, and that's informing, where it says, you know, the whole object of the exercise is informing and improving health and care services. Is there any evidence that you have got, you know, on your horizon, you know, built into your development program that says this is what we would be looking for in terms of the health of the community actually improving? Or is it simply that the organisation has some benefits from a health and care services point of view? I have a difficulty in understanding when you talk about health and care services, whether you're talking about the organisation or what the organisation's there to do, which is improve the health and care, you know, of the community as a whole.
I'll try and take that. Thank you, yes. I suppose in answer to your first question, are we doing something to evidence that there's an improvement in terms of outcomes? Specifically, if I may, from my perspective, not me personally, in terms of this particular project. However, there are other pieces of work that are going on specifically around population health management and looking at long-term data sets, of which the Shared Care Record Initiative can input to that to hopefully evidence that there will be improvements in patient outcomes. So I can't speak specifically about that particular matter. However, what I can advise you is, as part of the work that Sam and I have been doing, we have been reaching out to colleagues off the back of certain discrete pieces of work as we bring in new integrations, new developments on in relation to the Shared Care Record. Mosaic, Lincolnshire County Council integration being a case in point, and ask colleagues, you know, specifically what benefits are they seeing. And almost within the first sort of few days, we had some feedback from some care coordinators working out in the community to say, I'm actually looking at it on the screen here, and if I may, I'll quote it to you verbatim. It says, as a team coordinator, the addition of the social care tab looked to enhance my accessibility enormously. Currently, I have to contact a duty worker in adult social care to obtain updates, taking up their valuable time. Having access to Mosaic via the Shared Care Record Care Portal means that I can be self-sufficient and responsive. So from my perspective, that's improving quality of decision making, improving the speed of decision making, removing a need from somebody to have to contact potentially somebody in adult social care. So that actually is playing to freeing up capacity as well. So I'd like to think that's just one example of some of the feedback we had fairly early on in terms of the go live for this particular initiative. It is at the moment, yes.
Okay, thank you. Do we have any further questions? No? Okay. In which case, I'm going to propose that we note the progress with the development of the clinical care portal in Lincolnshire, and we request a feedback update in 9 months' time. So do I have a seconder for that proposal? Thank you, Councillor Wootton. All those in favour, please show. Thank you. That's supported. And thank you very much once again for your patience and attendance today.
Lovely. Thank you for your time today.
We'll now move on to agenda item 10, the work programme. Simon.
Thank you, Chairman. If I could ask members of the committee to look at pages 98 and 99, which covers the future items. Added, in addition to the 3 items listed for the December meeting, there will be 2 further items programmed. One is in relation to the Hartsholme Centre, where there was an announcement last week in relation to its temporary closure owing to staffing issues. So that is the psychiatric intensive care unit for men, and the item will explore some of the issues as to why that has happened and what maybe some of the future arrangements for that service would be. The other item to be added to the list, and this will involve Andrew Morgan, the Chief Executive from United Lincolnshire Hospitals, plus the County Council's Director of Adult Care and Community Wellbeing, in relation to, I think, what we would call patient flow at United Lincolnshire Hospitals, which is everything from A&E and admissions to discharge. So those 2 items will be added to the list for December. I would also like to mention that during the course of the morning we did talk on the recruitment item that we had back in July. It is actually listed for an update on the 15th of March, but it's under the title NHS People Board, which I know isn't that clear what that item is, but that is the name of the entity which is overseeing recruitment, and that will pick up Councillor Chalmers' earlier point about that. And I think the only other point I would just mention is that we do need to programme in early 2023 responding to the consultation on the proposed closure of Ashley House following the decision at the last meeting to participate in that targeted consultation stroke engagement. Thank you, Chairman.
Thank you, Simon. Ray.
Thank you, Chairman. In relation to the UTC at Grantham, can you tell me if that item will include comprehensive details of what services will be provided at Grantham, and also whether the additional of the UTC Plus will be included as well, and also who will be presenting that particular paper? And also, because we've got the A&E as well, are we going to go into the afternoon? Because I'm sure it's going to be a comprehensive discussion.
Thank you, Councillor Wootton. Yeah, I think we are looking at scheduling into the afternoon. I think often the problem is we're going into the afternoon that we do find that members don't tend to stick for the afternoon session, and we do struggle sometimes to book people to do the afternoon session for our presenters, but it's more than possibly going to go that way. I think the UTC Plus has disappeared into the ether. It's just a UTC, it will be known as. But Simon, I'll allow you to come back on that.
Yes, thank you, Chairman. Yeah, in terms of presenters, it is currently as listed, which is Pete Burnett is the presenter, but as often happens during the course of the lead up to the meeting, other presenters are drawn in, but currently he's preparing the item, and I can ask him to include reference in the item as to what the planned list of services at the Grantham UTC would be. So I'll make a note of that. Thank you, Chairman.
Yes, Chairman, it's a very hot topic still in Grantham on the future of the A&E at Grantham. Thank you.
Yeah, noted. Thank you, Councillor Wootton. Councillor Parkin. Right, okay. It's East Lindsey on the same day at 2 o'clock start.
Oh, okay. So I was going to come for the morning and then drive it, sensible speed.
Yeah, I mean, on occasion it will happen, and unfortunately
It's only relevant with it being if it goes into the afternoon session. That's the only relevance.
I mean, all I can say currently is in terms of timing, we are looking for the Heart Song Centre to be listed in the morning. Certainly the A&E item will be listed as a, because of the availability of that is around 11 a.m, so that will be probably the second item. I'm just trying to fit the other items around at the moment in terms of slotting people in. But yeah, I've noted that information. Thank you. Yeah.
Yeah, we'll do our best. I think the problem is we are getting an ever-growing list coming forwards, and we've got to start tackling it, or we'll never get there. And some of these things, you know, if we leave them, they'll have been passed, and we won't have had a view on it. So that's why we're sort of now looking at afternoons as well. Any other comments? No. So we're happy with the work programme. Okay, well, thank you all very much for your attendance today. We fell behind at one point and now we've rapidly got back on time. So well done to you all and thank you very much. Thank you. Bye.